from aspiration risk point of view. When we are looking to the risk of colonizations, giving antibiotic in the ICU or admission to the ICU, chronic lung disease and anti-acid use, usually consider a risk of colonization with bacteria, intubation conditions as a risk in healthcare setting, prolonged intubation, re-intubation, emergency intubation, and also frequent ventilator circuit changes. All of these considered to be risk factors. Complications of mechanical ventilation is well known, and unfortunately with the VEE, usually we count all of them. So VAB, one of them, sepsis, one of them, ERDS, one of the things can be, considered sometimes a risk of mechanical ventilation, not a cause for mechanical ventilation, but a risk. Pulmonary embolism, barotrauma, and pulmonary edema. And maybe I will share the same, reference my colleague Dr. Abdurrahman just mentioned before. The reference that coming from SHIA and also adopted by ADSA and ABIC. This is in 2014, being updated in 2020, 22. And my colleague mentioned about CLABSI, and here we are looking to VAP. I will not go into more detail in that. The most important thing is this, table, and these tables, you can see there, the interventions, and also toward the right, the quality of evidence. And I will just maybe read the first, essential practices, like the first one, avoid intubations and prevent re-intubation, which is very important, and with high, quality of evidence, which is, very important. So whenever you can, a way or another to avoid intubations, it's good to don't do it, and also to make it as minimum as you can from duration point of view. Minimal sedation has a moderate, quality of evidence, and we have maintained and improved physical conditioning, and now we are talking in ICU about early mobilizations and even mobilizations while patient intubated, and this have, moderate, kind of, evidence. Elevating head of the bed to 30 to 45, it has a low, evidence. Provide oral care with, toothbrushing and also without chlorhexidine, and maybe I'll go there and talk about it in details in the next few slides. But generally speaking now, it's good to do good oral hygiene, chlorhexidine there. It's not a major thing that we are recommending right now. Also providing oral enteral and parenteral nutrition with high, evidence, and change the ventilator circuit only if it's visible with high, kind of evidence. So this is all more interventions. Down there you have some of not, intervention that SHIA don't recommend totally to do because there is no evidence that it will minimize, VAP. So I'll just advise you to go back and look to the very important, subject and very important, recommendations. This is for pediatrics, almost the same. I will not read it, but almost the same with different quality of evidence. As you know, all pediatric and neonatal VAB surveillance is not well established like adult. Still hospital, they are doing it, but it's not well established as adult. And the next, one or table of recommendations that there actually is for neonates. So what is the bundle? We are talking about bundle. We are talking about this, حزمة من interventions. That's very important. Hospital look at it carefully. They lump them all, most of these recommendations, into 5 main, kind of interventions. Elevation head of the bed to 30 to 45, daily sedation interruptions, peptic ulcer disease, prophylaxis, deep venous thrombosis prophylaxis, and daily oral care. And I will go one by one to tell you what is the rationale, why we are looking at them, and what is, the concern if you just look at them. So elevation bit of the head of the bed, it's very known that it will decrease the potential for aspirations. It's potential also that it will improve ventilation. The problem, it's most of the time it's not comfortable for the patient. Also sometimes the patient, they slide down, we keep pull them up, and this will cause more skin chaining and cause discomfort for the patient at the end. Sedation vacations, also this, it demonstrated use of overall sedation, so this will promote early, weaning from ventilations. And the problem with that patient will be in a lot of pain, anxiety, self-extubations is an issue, and also this will increase the risk of desaturation. Peptic ulcer prophylaxis, you have to understand that, and maybe mentioned before in the table, and one of the slide before, the antacid, it will increase the colonization of bacteria, and this will add, a risk for pneumonia. But generally speaking, ventilation itself and putting the tube in is a risk to have peptic ulcer disease, and this will cause bleeding. So with that, we have to look to this recommendation carefully, and we have to weigh risk and benefit. Most of the time, if the patients with low risk to have peptic ulcer disease, we should avoid it. If there is high risk, prolonged intubation, we should give, antacid. DVT prophylaxis, and patients, they are lying there, they are sedated, not moving, so there is a high risk of thromboembolism phenomena, there is high risk of pulmonary emboli, but the problem with bleeding is there. Again, we have to weigh risk and benefit all the time, and the risk now, it's more toward, DVT and thromboembolism and pulmonary embolism, so we have to give it all the time. The daily oral care, it's been actually established since 2010, with chlorhexidine being recommended at that time based on a study that done in Scotland, and just 1 year study, and FDA later on approved the 0.12% of chlorhexidine for use as a mouth rinsing. And why chlorhexidine? Because chlorhexidine can kill and prevent the biofilm on the teeth, which is called the plaque. And also it can reduce gingivitis. More recommendations coming afterwards saying that it's not true, and you can use just any tooth paste, or you can use also sterile water for brushing the teeth, and that's it. But anyway, it's not there anymore in the bundle as chlorhexidine. Pediatric literature bundle, as I said before, it's less well established from evidence point of view, though that is there, and the risk almost the same, and also preventive measures more or less the same, but it's not established as adults. We have a bundle, like a checklist most of the time. Most of the hospital doing it. We are doing it in our hospitals from National Guard point of view, but still we look to this carefully all the time. So how we approach it, and this has also been mentioned before from education point of view, and how we can implement some improvement. And when we are saying, do you have established a stewardship program? I think the most important question is, do you have effective, stewardship program? When it comes to infection control, hygiene program, do we have it? Yes, we have it, but is it effective? And this is the most, important question that we usually should ask ourselves. A lot of our programs, if it's not measured, it's not implemented in the right way, this is the main challenge. And generally speaking, and our colleague here mentioned before that team and multidisciplinary teamwork, it's the most important thing. We have to have successful interventions. We have to show that it's a successful interventions. We have to ensure that there's adaptability of actions, and have that culture in the ICU or anywhere where people doing the good, practices. With that, we will have, sustainability of action interventions, and also very important, the leadership commitment and governance. WHO mentioned that, clearly, and they put it into what we call the multimodal improvement strategies. And the idea is to build policy, procedures, put the evidence all in one document, and then we have teach people about it. Education is very important. Education is never, enough all the time, but importantly to check it, early on with some sort of piloting, and to understand that education is given in a good way, and it's enough for that, policy and procedures, including VAB. Then, implement it or sell it, then live it, and get all, the culture change you want. And this is the same for VAB, this is the same for hand hygiene, this is the same for CLABSI, and this is the same for everything. So we have to ensure that implementations, it's there, and there is a mechanism or approach for that. So is it effective for VAB? We can see in this study where we are looking to the blue one, when we are looking to the main, device-associated infection in the hospital, like, VAB, surgical site infection, UTI or CAUTI, and bloodstream infections or CLABSI. And the blue one is mean without infection control, and the rate is up. And with infection control, you can see that lower respiratory tract infection decreased by 27%, and surgical site infection decreased by 35%, and CAUTI or UTI decreased by 31%. Bloodstream infection in general or CLABSI decreased by good infection prevention control when it's implemented right, around 35%, and total all measures can decrease almost like 32% of the rate of infection. Can we achieve zero? Yes, we can achieve zero of preventable, device-related infections in the hospital. Again, VAP was looked carefully in this, multifaceted interventions from a lot of studies, and at the end, totally, when it was in different settings, like high income, upper middle income, and lower and middle income countries, and in general, 45% can be, decreased from infection point of view for VAP. This study was done in National Guard Hospital in Riyadh between 2010 to 2013. Dr. Balkhi and Dr. Majid Thaqafi, they looked at compliance to bundle. So the line up is compliance to the bundle. It was 86 early on, it went up to 99%, and today, when it reached 99%, we achieved zero VAP in the hospital. So this means that it's effective when it's implemented in the right way, and also measured and looked at carefully all the time. So we reach two conclusions. So VAP and VEs are preventable hospital-acquired infections. Effective measures were described and well studied in literatures. The problem all the time is implementation, so we have to look to an approach to achieve implementation in the right way. And this is actually the most challenging point in infection control. Thank you very much.
Thank you, Dr. Majid. We need just 2 minutes to resume our talk for technical issue. Just 2 minutes. Thank you, Dr. Majid.
بسم الله بسم الله.
Our next speaker, Dr. Salma Al-Bahrani, infectious disease consultant, head unit for ID and chairperson for antimicrobial stewardship committee, King Fahd Military Medical Complex, Tehran. Welcome, Dr. Salma. She will present the prevention of MDR or organisms and outbreak in the ICU, how to be and where to focus.
Okay, so good morning, everyone. Thanks for being here this morning. It's really my pleasure to talk today about the prevention of multi-drug resistant organism transmission in the ICU, how to begin and where to focus. How to begin. This is really a difficult situation, and it's very important nowadays, especially with the burden of increased MDRO rate globally. It's a very huge talk. I consider myself that I put just the headlines as an open eye for you, then you can search and read more, expand about that topic. So for my outlines, I will just talk in brief about MDRO definition, just as a refreshment, and MDRO of concerns, AMR prevalence worldwide and Saudi Arabia, risk factors for MDRO in the critical care, then my main topic about multi-component strategy to reduce MDRO rate and transmission, which consists of 2 strategies, antimicrobial stewardship, then infection control measures. For definition of MDRO resistance, we call resistance when it's resistant to less than 3 groups of antibiotic. MDR, resistance to more than 3 groups of antibiotic. For XDR, when it's resistance to more than 3 groups of antibiotic and sensitive to less than 2 groups of antibiotics. For BDR, which is banned drug resistance, resistance to all the groups, and isolate should be tested for all the agents in every category. For difficult to treat Pseudomonas aeruginosa, it's resistance to all the anti-pseudomonal agents, including carbapenems. For CRE, we have 2 types, carbapenemase producing and non-carbapenemase producing. For carbapenemase producing, we have 3 classes. Class A, which is KPC, Class B, metallobeta-lactamases, Class C, oxacelinase, OXA48, and it is of high level resistance. For non-carbapenemase producing, we have beta-lactamases, or by the method of increase the efflux, or by the method of increase cellular permeability. And this is of low level resistance. So what the MDRO of concerns? We have the mnemonic of escape pathogens, Enterococcus faeciums, VRE, Staphylococcus aureus, MRSA, Klebsiella pneumoniae, ESBL, CRE, with all of its carbapenemase types, Acinetobacter baumannii, multi-drug resistant Acinetobacter, or bicarbapenemase, Pseudomonas aeruginosa, multi-drug resistant Pseudomonas, or the difficult to treat Pseudomonas. Then we have the spice pathogen with inducible resistance of AMP-C. Also, we have the non-traditional multi-drug resistance that could be counted as MDRO by infection control, Clostridium difficile infections, and Candida species, specifically Candida auris. So why does this matter? So the proliferations of these superbugs means that we are running out of solutions and that we cannot treat these infections. There is increasing morbidity and mortality, and it will affect the people's life. So there is a very good article released recently about the world in which we live. So antibiotic resistance has become a real global pandemic, and we should call it silent pandemic. The rapid emergence of CRE represents a major threat. In all reported outbreak, it's mainly caused by cross-transmission in the hospitals. No antibiotics to replace these classes seems available in the next 5 to 10 years. ICU are typically the wards where resistance problems emerge first and has its largest impact. For AMR prevalence, in short, for the recent CDC released guidelines, it has been increasing the infections and also increased the deaths related to MDRO. With that, there is also increased C. difficile infection related to overuse of the antibiotics. This was released in 2019 from Lancet, the global burden of bacterial antimicrobial resistance in 2019 as a systemic analysis. It has linked 1.2 million global deaths in 2019 to antimicrobial resistance. And also this is data done by our Prof. Aliou and his colleagues in 7 different hospitals over 6 years that they monitored 3 types of organisms, Stenotrophomonas, Acinetobacter, Pseudomonas aeruginosa, and they looked at the sensitivity of the antimicrobials over these 7 years. What they saw is that they were, the sensitivity were decreasing over the years. There is also a big talk about the eye-opening that COVID-19 accelerated MDRO or AMR, and it's considered to be the perfect storm for the effort to reduce the antimicrobial resistance. And CDC released their report of increase by 15% of multi-drug resistance related to COVID-19. And this was correlated with the 80% of the most of the hospitals, most of the patients of COVID admitted or hospitalized, they did receive antimicrobial, and also many theories raised about the causes of COVID and AMR. And also they release the risk factors why multi-drug resistance increased with the COVID-19. They correlate that with the age, the long-term care facility stay before the diagnosis of COVID were mainly associated with MDRO after COVID. Also, the central venous catheter use, the mechanical ventilation, the use of systemic corticosteroids were very important contributing factors. So the risk factors for MDRO infection in ICU is correlated with the old age, functional disabilities or functional independence. Lack of functional independence was also considered, comorbid diseases, long-term care facilities of the most of the admitted patients in ICU, medical staff is a contributor factor for the transmission, shared equipment, recent surgery or other invasive operations, antibiotic exposure for sure was a risk factor for MDRO. So by WHO by 2015 endorsed global action plan to combat the drug resistance. And it has many multiple action plans, including the measures of infection controls and antimicrobial stewardship. So we came to our main topic, multi-component strategies to combat MDROs in critical care. It's of multi-component strategies, consist of infection control, mainly infection control measures, including surveillance, specific device-specific strategy, digestive and oropharyngeal decontamination, decolonization, patient bathing, contact precautions, cohorting and dedicated staff, hand hygiene, antibacterial curtains if you have open ICU, environmental cleaning. All of these considered to be horizontal strategies, but only for active surveillance, this is considered to be vertical strategy. What we mean by vertical strategy, that it's targeted to specific pathogens to be screened for, but horizontal strategies is directed to all the possible pathogens to prevent their transmission. In addition to these strategies, definitely antimicrobial stewardship program is very important to reduce the transmission. So for vertical strategies, which is the active surveillance culture, it depends on the iceberg principle. Don't concentrate in the seen part of the tip of the iceberg. Maybe the unseen part, which is under the water, not seen, is the contributing factor for the whole major problem. So the seen part is the MDRO infected patients. We act reactively once it's diagnosed, and then we start our precautions, isolations, BBEs, but we forget about the MDRO colonized patient. They are not seen, and they contribute for the silent transmissions that we should be careful about. And that's why we have to strategize the surveillance cultures. For ICU, I think it's a must, for our military hospitals, must to be done in all the ICU patients, maybe MOH also follow that, but also we have to strategize outside the ICU critical care patients, that we put criteria where to do the surveillance culture, because they may transmit it to patients, will be your patient in the ICU later on and will contribute to the transmission. So active surveillance culture is very effective in controlling outbreaks, identifying asymptomatic carriers, providing accurate data in the prevalence of MDRO in the hospital, guiding your empirical antimicrobial therapy in sick patients, decreasing the rate of hospital-associated infections. It will make the infection control measures more focused, and also it may identify for you the emerging or novel pathogens and resistance mechanisms. For example, if you did this screening for Candida auris, that will point you to possible ongoing outbreak, then you will act cautiously. Also, when you plan for active surveillance culture, you have plan it smart. So you look at the pathogen of concerns, epidemiological settings. If you have more of CRE, Acinetobacter, you will concentrate on these. Targeted versus universal screening, also you have to plan it and think about the cost effectiveness. Screening methods, will you use the conventional cultures versus molecular? This depends on the hospital resources, but also molecular is much more important because of the rapid results. Sites of the screening based on the anticipated colonizations. For any organism you want to look for, there's a specific way and sites. Frequency and durations, how frequent you will do it in the ICU. So once the patient admitted, upon the admission, then every week if he was negative. Outside the ICU, they have different frequency, different durations. Measures to be implemented for colonized patients. should be also considered and planned. Cost effectiveness of active surveillance culture also must be planned smartly. Now we came for the horizontal strategies. Antimicrobial stewardship program, for sure, everybody aware about it, of its importance, and decrease the antibiotic resistance, decrease C. difficile infection and the cost. At the same time, it increases the good patient outcomes. It's a win-win strategy. You will improve the outcomes, at the same time, you will save the cost and save the life. It has two different strategies. Also, I think most of you are aware about it. Pre-authorization and restriction, only restricted to the authorized people, clinical pharmacist ID or ID physicians, or the audit, prospective audit and feedback. So it's open to everyone. Then you go and meet the prescribers, give them feedback, and reevaluate the prescribed antibiotics. And we will not forget the point of care intervention with the antimicrobial stewardship, the antibiotic selection, de-escalation, dose optimization, duration, drug monitor, IV to per oral conversion, and monitor for side effects. All of these included in the program. But for the ICU, antimicrobial stewardship, it's slightly different. Intensivist face a challenge of balancing. He's having a very sick patient, but at the same time, he must use the most appropriate antimicrobial, empirical antimicrobial coverage, not to be of narrower or too much broader. It depends on the situation and his scientific guess. The initial antimicrobial management of sepsis also critical. Some of the studies favors prospective audit and feedback by the pharmacists and physician trained in ASP, then reevaluate the empirical coverage after 48 to 72 hours. But also formulary restriction of selected antimicrobial in the ICU, it's very important. Here, it's a data show that the improved susceptibility of gram-negative bacteria in the ICU after applying a compromised antimicrobial decision support system as part of ASP program, and it did show a significant promising results. And here, this is a very important data about the antimicrobial stewardship in ICU. Did it affect the mortality or not? And this is a very frequent concern from the intensivist. By applying restrictions, applying the antimicrobial stewardship, will this affect the patient's, ICU patient's life? And here, this is a systemic review released in one of the biggest journal, Clinical Infectious Disease. They looked at the data or studies where they compare the death rate and the numbers before the intervention of ASB and after the intervention, and didn't show any change or increase in mortality after applying the antimicrobial stewardship. Now we came to our infection control measures. Before I go through that, when you are going to look at your infection control measures, you have to look at the setups of your critical care and the organization of the ICUs. Is it following the FGI and EPIC system and related to infection controls? It requires really intelligent planning. And as per guidelines, it's favor the multiple units, not to have only AICU. You have to have surgical ICU, burn unit, and CICU or CCU. It should be of high visibility, to be made all of glasses, and decentralization of nurses station. So most of the nurses should be in front of the patients, not to be of a central station. For good visibility, single room for each patient is the most favorable in the ICU. Not joined room, not open ICU. So closed ICU is the most preferable. Isolation room, negative pressure should be of 10% of the total ICU beds. In open ICU, you have to have 150 to 200 square feet area per open ICU bed with 8 feet between the beds. So this distance is very important in the ICU. Hand basins for hand washing, 1 for every 2 patients if you have open ICU, and 1 in each single room. BBE sets should be directly accessible for all the staff. So this is a diagram show you the best setups for ICU critical care of high visibility, open for glasses, and also the stations of the nurses should be in front of the patient. And this is if you have an open ICU, it's preferable to have partitions between each patient and the distance we talk about it. If you don't have these partitions, antimicrobial curtains, it may play a role. So we started with the first measure, hand hygiene. For us, we know that this is the simplest measure, but the most important one. WHO 5 moments of hand hygiene should be applied. Adherence remain as low, and in some studies is lower in the ICU than the other wards, so where we should concentrate on. It's of alcohol-based hand hygiene, but also hand washing protocols is very important for certain concern like C. difficile, norovirus, or spore-forming agents. This is the update of 2022 about the hand hygiene by SHIA IDSA. Here they concentrate about the nails and the replacement of hand sanitizing stations. Their recommendations were categorized as essential and basic practice, different from the previous. They talk about the products, accessibility, hand washing sinks, and monitor adherence that must be done with the frequent rounds by infection control. And they talk about the methods how to measure hand hygiene. Here they summarize these methods. The first one is direct overt observation by infection control practitioner. They go and observe the hand washing, but its weakness that it may lead to Hawthorne effect. So the people who improve their procedure or their compliance once they see someone observing them. We have also the other way of measures is direct covert observation by secret shopper from the unit itself. They direct observe their colleagues. Automated hand hygiene monitoring system by alarm specific system. It's of highly advanced, and it's a very that gives the staff alarm once they pass over the dispenser and they didn't do the hand hygiene. Video observation, patient as observer, and indirect measures by looking at the product. So once you put the dispenser, we do it in our hospital, we put the dispenser with the date of opening it, then after a while we look at it if it was consumed or not, so we make sure that this unit were compliant to do hand hygiene, and also audit of accessibility by the matman and supply chain. Then we came to the second part, second measure is contact precautions for all MDRO. Most of the units should be compliant to cohorting the MDRO cases together if we are in short of bed, and did it also cohort or dedicate the staff to take care of MDRO cases. So contact precautions of MDRO must be done proactively and reactively, and universal contact precautions, they are talking about it so that any patient in the ICU, universally you apply the contact precautions. It's of ongoing debate. Some of the data, they go with it, and other studies, for example here, randomized trial, they didn't show any added benefit. Maybe a reasonable practice in case of outbreak. Cohorting MDRO carriers of the same strain, also with the dedicated nursing, it's of importance, but we have to be careful about the cross-resistance transmission between these patients. So they are both of them, they are MDRO, but of different strains, so we may go for another problem. Decolonization patient bathing, daily bath with 2% of chlorhexidine from jaw to toes, it's prove its importance. Eradicate carrier of potential pathogen and decrease the risk of invasive infection, also it have been proven in multiple studies. It is of the strongest evidence mainly with the Staph aureus, but also we use it for other MDRO. Daily bathing also decreases the skin colonization for MRSA, VRE, CRE, and it reduces the CLABSI rate, and this is also of a strong evidence. Here it shows you how chlorhexidine body bath reduce healthcare associated bloodstream infections, and by looking at this graph, it favors the chlorhexidine bath. But here it may give you some limitation of its use, especially if you would decide to use it universally for all the patients. That this study, they report the effect of antiseptic protocol and acquisition of both endemic MRSA and the strain carrying QACA-B genes, which is resistant to chlorhexidine. And it was done in two 15-bed intensive care unit using segmented regression models. It did show 70% reduction of MRSA, the regular MRSA, but unfortunately there was increase in TW-MRSA strain, which is resistance to chlorhexidine.
5 minutes left, Doctora.
Okay, I have to run fast. Digestive and oropharyngeal decontamination. Also, there is a big talk about it. They use multiple regimes. In Netherlands, where they do have low baseline antimicrobial resistance, they do follow this protocol. Also, there is a release data about probiotics used through nasopharyngeal. Device-specific strategy, it have been talked about by my colleague about these are the most frequent infections in the ICU, CAUTI, VAB, and CLABSI. What I advise for as infection control point, that we do a checklist and we follow the competencies and the compliance to these. Then we came to the environmental cleaning that it considered to be of potential risk for the transmission of infection to the patient and healthcare workers. We have to concentrate on, and the organisms or MDROs, they are really highly sticky to the environments that we should be careful and meet the housekeeper responsible person for the environmental cleaning. So we should review the strategies, identify the person responsible for patient zone as the nursing, for the outside patient zone of the housekeeping. We look at the frequencies, method, process, and also you should create a clinic cleaning checklist that these people should follow to follow also to make sure about the efficacy. And the cleaning methods, it was mentioned in the CDC that you start from top to the bottom, from the dirtier to the cleaner, and also you should follow clockwise in the cleaning. These are very important contributing factors. If the housekeepers not following this, it will lead to transmission of infections. So you should always meet the housekeeper and educate them. Then the recommended frequency for cleaning twice daily should be in ICU with specific detergents, specific concentrations. You should schedule it, and also when the patient is leaving the room, you should do terminal cleaning. Supplies should be dedicated from the housekeeping dedicated to the ICU clinic. I'm running fast. Still 5 minutes. We have different types of environmental cleaning: hydrogen peroxide vapor, ultraviolet light decontaminations. It's very expensive, although it's very easy and effective, not widely available. Terminal cleaning, it's very important. It's the whole thing about. So we should always concentrate in these responsible people. Now we came to the antimicrobial curtains, especially if you have an open ICU like we do have. Privacy curtains is a very potential for transmission of antimicrobial. And the antimicrobial curtains, it's very important that it's prove its efficacy in preventing the transmission of the infections. Here is one of the studies done comparing the privacy or standard curtains with the antimicrobial curtains after intention contamination. These antimicrobial curtains were much lower than the standard curtain in organism contamination, and it have been evaluated after 2 months also. It was much lower than the standard curtains. But here, this was an idea from our department that to recharge the curtains. So the antimicrobial curtains, definitely it's not like the closed unit. So this review or study did talk about the halamine, which is the antimicrobial in the curtains. It may sometimes lose its effectiveness over the time. So you can recharge it by using disinfectant spray in these curtains, and it may be effective in preventing the contamination. And we start to use it in our hospital. We are doing it as pilot study. Now we finished the measures, but there's a very important point in the ICU and infection control, engineering. So engineering play a major role in the ICU by looking at the air filtrations, pressure difference, also looking at the air changes, especially in negative pressure room, and also cleaning the AC ducts and the filters and the vents also play a major role, especially for the organisms known to be of air or humidity lover. Construction and infection control rules, also it's very important. Once you know that there will be a construction or renovation in your critical care unit, there is specific strict measures must be followed and agreed by infection control by putting partitions, barriers, then after that you do the cleaning, terminal cleaning and fumigations. The last slide is build up your relation with the ICU staff. Periodic training, educations, share with them the data, and always monitor for their compliance for the measures and the procedures. Thank you very much.
Thank you, Dr. Salma, for this comprehensive speech. Now, if there is time for discussion, few questions. So, few questions allowed. Please, Dr. Abdurrahman, Dr. Majid, Dr. Salma. If there is any question from the audience, please. We have 5 minutes for question.
I have a question for Dr. Abdurrahman. I was excited to see the table that you have presented about the MOH data for patients, including CLABSI, but I never seen this distributed to all hospitals. And also, there is no risk stratification. They are making it regional, and this region could have high-risk ICU, low-risk ICU, surgical, medical, mixed, like, teaching, non-teaching. Again, it is not using the NHSN stratification risk for ICUs. So I know that I never seen any national data for MDRO and for device-associated infections to benchmark our rates. Correct me if I'm wrong. Thank you.
Thank you, Doctor. This is from, if you have Hassan, I think you can access the rate. This is accessible, and you can ask it from Ministry of Health Infection Control Department, and it's available there by region. They put it by region, and they put it by also units. And they launched last year the CLABSI, and this year they started to launch the county to get a zero. And they are working actually hardly, and they are communicating with the private hospitals also and other Ministry of Health hospitals, private hospitals, and other hospitals like Ministry of Defense and National Guard and King Faisal and other hospitals. I think that the Ministry of Health, they are working hard to make sure the CLABSI, and you can reach through the HSN. If anyone in your institution has access to HSN, you can reach the data and you can extract the rate in your region. And if you want the whole regions, you can ask it from the Ministry of Health Infection Control Directorate Department.
I never seen, they are behind us, on top of our heads, to report the public health, the COVID-19, the vaccination, everything. But I never seen any reminder or obligation to report the healthcare-associated infections or device-associated infection or MDROs. And correct me if I'm wrong, because I never seen any distribution. And I know that Dr. Majid is here and Dr. Salman maybe.
I think, as I mentioned, the Ministry of Health, the Infection Control Directorate, they are working nowadays on this issue, and it's a critical issue. And they are communicating. Were communicating. Now they are starting to communicate more with the private hospitals and other institutions to have a better outcome of the CLABSI and the COUTI and the VABs and other related infections.
Thank you, Dr. Abdurrahman. If there is any question, please.
Assalamu alaikum. Thank you for the nice presentations, Abbas al-Mala'an. I have the question to either one of you, Dr. Majid or Dr. Abdurrahman or Dr. Salma. What is from your experiences and what is available in the research, what is the best approach to monitor the compliance with the bundles of care in terms of the MDRO, the COTI, the CLAPSI, or the others? So if you can elaborate on that, please. Thank you.
You first, then I'll come after. No worries.
Thank you for your question. Honestly, what I think that infection control practitioners, they should do frequent rounds. Their presence in the critical care is very important. Once they do the rounds and observe every day, giving their comments, feedback, and also report. So what we used to do in our hospital, that the practitioners, every day they change their timing. They used to do it in the morning, for example, in one day. The other day they would do it in the afternoon. Then after that they would report their findings. And for us, we report this to the head unit of the infection ICU. And this we found it very beneficial. Most of the people, they start to be compliant. Even the people, they are not compliant or arguing with the compliance. For example, we face a lot of physicians, they refuse to wear the PPE or they forget to wear it, then they said, okay, so what? When we report their names, it makes difference. So this is really the main part of the compliance. That's what I think. I don't know, Dr. Majid.
Thank you, Bassett. I think this is very challenging questions because, as you know, that how we, report the bundles. Usually, it's self-reporting and checklists. Usually, paperwork or electronically there in the system, and people they will come most of the time afterward, and they just do this these checklists. So there is a lot of bias here from are they doing it right or not, and the question usually how we can ensure it's the accuracy of these data and it's there in the system all the time in a validated way. Still we have to do it in the same way, but we have to select some of the cases where infection prevention control or preventionists do their own audit and compare it like sampling size. Let's say we have 100 number of bundles being reported from one of the ICUs. At least 10 of them, 20% of them was under direct observation, directly from the infection control preventionists or the champions in the ward. Because like in National Guard, we have 2 link nurses in every unit, and they are champions, and they do this kind of audit, direct observation, just to close that gap. And we have to do these validations every now and then to be sure that the data is accurately, being collected. Thank you.
Thank you, Dr. Majid. Dr. Salma, one more question.
Just if you don't mind to comment on universal gowning in ICU setting. This is how we balance the evidence for such practice. In certain ICUs, we do recommend this when there's significant outbreaks of MDROs. Other ICUs, we keep it open just for only limited for the ones who are colonized with MDROs. Just to comment how we balance the evidence and the importance of, or like the difficulties we face with universal gowning in terms of entering the room for the physician and do the exam. Thanks a lot. Dr. Majid or Dr. Salma.
I'll start first now. It's not ladies first. First me, then I'll give it back to you. Universal, kind of contact precautions and being looked at a lot in literatures, and most of the time, it didn't show much benefit, and actually in some studies showing that it may have a risk of contaminations, and the healthcare workers contaminate themselves and rely on them too much, even to forget, hand hygiene, and especially in busy ICUs. So generally the recommendation against them. There are especially, kind of situation when we're recommending them, especially during outbreaks, if they are outbreaks. And I'm talking about contact precaution, not, the mask, universal masking. Universal masking is something else, but I'm talking about gowning and gloving. So generally, it's the recommendation against them, and it may have more risk unless you use them in a certain conditions where we have an outbreak. Thank you.
I agree with Dr. Majid, exactly the same. It's often going debate, but you use it in certain conditions. Also, it's the cost effectiveness. We have to evaluate this limited resources, especially after COVID. But in ICU, I think we feel that we are not really in need for universal gowning and gloving because we are doing the molecular type of testing for screening, active surveillance, and you put the patients while they are in active surveillance period, you will put them in isolation. After you have the results of negative, you will open the isolation. So we feel somehow we are protective from that point in ICU.
I agree with our colleagues. It has actually a negative impact on the wastage of resources. We notice it after doing for certain period universal masking. There was a misuse of the gowns and the gloves and misuse and also underuse of the proper other hand hygiene, for example, and that leads to cross transmission actually, and not to prevent the infection. So this is, I agree with our colleagues, it's not generally recommended, unless in very certain limited situations and time.
But also we have to mention that we are doing active surveillance. We repeat active surveillance 48 hours after the first screening and weekly if the patient is staying in ICU. So it's not going to be one surveillance, it is repeated surveillance to ensure and calculate the acquisition rate for MDROs.
Thank you all. Last question by Dr. Zainab.
Actually, it's not a question. I just want to thank you about the rich discussion. Just a little comment about the self-reporting. What Dr. Salma mentioned are great, like changing the timing of the visit to infection control, and I think this is a good learning point from our point. But I think wherever you change the timing, there are after hours, which is the most critical, like the night, and I think self-reporting require a high level of maturity and accountability, okay? And we cannot reach this. We always hear about non-punitive. It should be non-punitive approach. You shouldn't like punish the staff for making mistakes. But how can we reach this? I think setting an example by the leadership that I will report if I make a mistake, I didn't wash my hand, I will report myself, for example. When the JCI come or Sibahi, I will present my data in very transparent way. I will not hide any data. This will set the example for all frontliners that self-reporting is good, is beneficial. It's for the patient safety, actually. So just a highlight on that point. Thank you.
Thank you, Dr. Zainab.
Hello, hello, you hear me? Well, I think we have, for the sake of the time, we have to end the discussion here. We will have an interactive session immediately after this, so we can have all of these questions again, please. But we have to finish here, and thank you for everyone. And please, Dr. Zainab, come here. Dr. Yasser. Just please, after the break, we have to take a very short break, so please grab a coffee and come back. You can drink your coffee here, or you bring whatever, you can drink it here, so to start early. And we will have the interactive session later on, so please, if you have any questions, this is the time to ask and interact. Now, we will recognize our speakers and moderators. Dr. Yasser.
We would like to thank our speaker and moderator in this session. Amazing, it was amazing session. we'll start with Dr. Abdurrahman Al-Adayani.
consultant adult infectious diseases. Our session is about infection control prevention, pitfalls and challenges in the ICU. So if you can scan the barcode so we can answer the questions. Okay. The first question is, do you perform active surveillance cultures in your ICU? Okay, the majority are doing active surveillance cultures in the ICU. So I'd like to hear from our experts about the importance of doing active surveillance in the ICU. Is it indicated routinely or not, only in the ICU or in other areas? And what's the evidence behind that? Dr. Ali?
السلام عليكم مرة ثانية. بالنسبة للسيرفيلنس يعتمد على what do we mean by active surveillance. في سيرفيلنس بيتعمل على دخول المرضى إلى العناية المركزة أو للبرن يونتس أو لمعرفة talking in Arabic. There is an active surveillance that is being done on admission, especially for high-risk areas like ICU, burn units. It's to understand exactly what do they have, what do they harbor as a colonization or as an infection. It has to be guided and it has to be done in a protocol way. Which areas that they are supposed to take and how do they do it, and also for the lab exactly what they are going to be reporting, and the exact report has to be standardized in a way that the practitioner or the one who's doing the auditing on inside the ICU understand that report and what does it mean. The other active surveillance is the one done on weekly basis or on a monthly basis, or when there is an outbreak or there is an increase or surge in certain infection. And this one is also had to be guided in a way to understand from both sides, i.e. from the practitioner who's doing the swabbing and from where and when to do it, when there is not much load on the microbiology. On the microbiology side issue is also to do the direct surveillance for these MDROs or for general use, i.e. doing non-selective media. And also to do it in let's say that we have a Clostridium difficile infection that are happening in the unit, and there are 3 or 4 cases. We're going to be selecting what kind of sample that we're taking from the patient, and the lab has to have a turnaround time, and also what to do with the result when we have a positive one who had no symptoms, where to put him, and if we have that facility.
I agree with what Dr. Ali said. So active surveillance culture is a very important question to be asked, and still unresolved issues. So I will tell you what's the reality, what we are doing in our hospitals, and what's the scientific evidence now with the current recommendations, and what's the scientific evidence. So what we are doing in our hospital in King Fahd Medical City, we consider ICU is a high-risk unit, either general ICU, cardiac ICU, neuro ICU, cardiovascular ICUs. So those are harboring immunocompromised patients or very sick patients. And so the recommendation there, we are doing on admission screening cultures for the MDRO, MRSA, VRE, and gram negatives. And we include Candida auris also, since we have sustained high level of Candida auris infections in the communities, in our neighbors in hospitals, and in our hospital also. So it's on admission screening to the ICUs.
and then weekly screening in our unit, and upon discharge from ICU. Do we do screening outside the ICU, active surveillance cultures? The recommendation is to do it for hematology oncology patients. Those are immunocompromised. So actually, we are not doing it, but we are restricting this surveillance in the ICU unit. What's the benefit of this surveillance culture? Once we get the results, so there is expected actions. So expected action to isolate the patient and to minimize the cross transmissions. So it's very important for us. There is now emerging evidence that the utility of this approach is not, it's highly beneficial, and there is conflicting result about it. The problem with this, such studies in the active surveillance and isolation of isolation strategy, they are doing such studies with parallel interventions, so you cannot determine the end result of the active surveillance because there is ongoing infection control intervention measures. So in the United States, for example, if we talk about MRSA and VRA, they are starting not to isolate the patient, not to do surveillance, but the reality there, they have an excellent hand hygiene rate and excellent cleaning environment protocols. So as Dr. Salma in her presentation, the horizontal measures, it's almost near perfect. So this is the thing. Also in the lecture of Dr. Salma, she said that the hand hygienes in the ICUs, it's very low. This is reported in the scientific evidence. And this is because of a lot of opportunity that is needed to communicate with the patient. So it's the staff there is burned out. So it's the hand hygiene. Usually the rate is actually the average is around 40%. So the recommendation now we carry the recommendations. This doing active surveillance for MRSA, VRE, and MDRO and Candida auris. But the question now, some emerging organism like Candida auris, from where you do the screening, and what is and there is something they will come in few days about in few months PCR for Candida auris, but Candida auris from where you can screen for surveillance cultures, and what's the best? There is suggestions from inguinal, nasal, and axilla, and Acinetobacter also. So a lot of questions about active surveillance, but if the hospital resources cannot afford and microbiology lab cannot afford, so you need to choose the setting. For example, if you have high endemic rate of such organism, you want to control it, or there is an outbreak. But otherwise, if you have a good resources, I think it's reasonable to conduct active surveillance limited to the critical care units. Thank you.
Thank you very much. The next question is also related to surveillance, just to add to the discussion and the confusion maybe. Which organism do you do active surveillance for? ESBL, CRE, Acinetobacter, MRSA, VRE, or others? I hope this we have the option of getting multiple answers at the same time. I'm not sure. It's not? For all answers will be wrong. Okay. Or you can choose the most important. Others, or all. If you choose others, it means more than one, or all of them. Okay. I can start with Dr. Ali. What do you think?
Yes, I think it's a good answer that to say it's more than one. It used to be, 20 years ago we were more concerned about MRSA, and at that time it was mainly the MRSA that we are screening. But over the years, we could see that there is an increase of Acinetobacter, and recently, not recently, 10 to 15. could see that the Klebsiella is increasing, then the resistant Pseudomonas and the ESBL, and now the Candida aureus. I think it's depend on the institution in our the country. In our country, I think we have to screen for all, i.e. for MRSA, for Acinetobacter, for ESBL, and for certain population that are coming from, knowing countries or knowing travel history, we screen for extra.
So again, it's we screen for all as per recommendations for MRSA, CRE, Acinetobacter, VRE, and ESBL. Again, there is now article that's published few weeks ago in American Journal of Infection Control that even contact precaution is not required for ASBL if there is good hand hygiene practice and other measures. But if the lab said I don't have resources, so you need to choose which organism, I will choose the organism that is high concern, high endemicity with me, with worse outcome like CRE, Acinetobacter that don't have options for treatment if disseminate. Thank you.
Excellent. Regarding surveillance, anyone has any question or a thought about surveillance? Dr. Mustafa, go ahead.
Well, about the ESBLs, I know we have been debating this for some time, and with the now presence with much more problematic and resistant infections, and I guess there is some establishment of the ESBL in the community as well. So how much emphasis we should put on the screening and isolation, even isolation for patients with ESBLs?
So we noticed that there is increase in the trend of community-acquired ESBL. So the question is if there is, I'm not sure what's the figure, but it's high. I think it's around 30–40% in our country, in Riyadh city. So it's now you need to balance the cost, balance the risk of transmission of infections. Again, if you have a good setup for infection control, good infection control programs, we would go with just enhancing the other measures of horizontal strategies like good hygiene in the room, good hand hygienes. But if we reach to a stage that it's highly endemic in the community, probably just stressing on the effectiveness of infection control program within the hospitals.
The well established is for MRSA and VRE because we isolate them, we prevent the transmission inside our units. For ESBL, it is, there is doubtful about what to do with it, especially if there is a community already established have a background of these kind of ESBL. It would be beneficial if you have it, if you know that your patient have it. It's for the selection of the antibiotic that patient became septic down the road. But for infection control, I would probably be in the middle. For CRE and for Acinetobacter, it's also for a certain population that are coming from an endemic environment. It used to be a Ministry of Health institution when they are giving, transferring patients from MOH to our hospital, we screen them for that. But nowadays, it's also inside our hospital and it's coming from, everywhere. So we do screen them for that.
And I just want, I'm sorry, just to a bit elaborate more about the ESBLs. They are there. I don't think we will do anything with the ESBLs. I'm not sure if we can, if any efforts at this time will make it decrease. And the other thing about the ESBLs, they're not a major concern for management. Previously we had issues with the management of ESBLs, but nowadays, the concern is more for the more resistant pathogens. And we already have some established good therapies. Still, we have good therapies for ESBL. So if you want to choose where to spend your money, maybe this is not the best pathogen to spend money on at this time. When we have all of these pathogens happening, and in addition to these, We have the newcomers, the Stenotrophomonas, the Burkholderia, the Elizabeth Kingia, the Achromobacter. We started to have more and more. And actually the Proteus, which will probably be one of the most nasty and the new MDRs that are, as we know, we have a Proteus that is already resistant to imipenem, available everywhere. And when you lose the carbapenems, you don't have much options. Colistin, tigecycline are not an option at all, and you're still left with ceftazidime, avibactam. So I mean, if we want to choose wisely where to spend our money, maybe the ESBL is not the one to chase at this time.
Because of this, a good microbiological, consultation, and also with the method that they are using now, with the selective media that they will look for, they could pick up more organism for you. For the ESBL, CRE, it is easier for them to do it on selective media.
There are challenges for the doing surveillance. For example, one of the challenges is the supply issues, especially for CRE. For example, the PCR kits is expensive. Sometimes we are facing a challenge with the availability of the. This is one issue. Another issue is post-surveillance. If you identify, it's good to identify the MRSA, CRE, VRE patients in the ICUs, and you will manage them, you will isolate them, you will implement them. But once they are stable and the intensivist want them to be out of the ICU, sometimes you will be stuck with those patients. You don't have in the ward, for example, single rooms or dedicated rooms for, you cannot cohort CRE sometimes with VRE, you cannot, but I think there is a challenges in these two entities, the supplies issues and post-discharge from the ICU, the bed situations, how to isolate them and how to.
I think there are a lot of debates and controversies around the surveillance, the site of collection, how many sites collected together or separately, and maybe the other last challenge that we have from the GDIBC that we have to report every MDRO screening through Hisn, which is needs a lot of resources. So this is another challenge maybe.
This is part of the transparency. This is part of, yes. Doing things for the sake of the patient. I know it's more work, but it's for the benefit of the unit, for the benefit of the community.
I agree 100%.
Just important point, Dr. Zainab, you mentioned, that's reporting. So if you are doing a lot of surveillance culture, we'll catch a lot of MDROs. The other hospital, they are not, the other MOH hospital, they are not doing this surveillance since the resources is not met there. So this will reflect our performance and says you have issues with your, otherwise no, we are screening on admissions weekly, it's active. So it's a very valid point to be raised to the MOH.
Yes. We'll go to the next question. Targeted decolonization for MRSA, all MRSA carriers is routinely indicated. Agree, disagree, or neutral? And we're talking about ICU patients here. Dr. Faisal, what's your thought about decolonization?
In regard to target decolonization of all MRSA carriers, what's the evidence is strong. If we say outside the ICU, this is for those who's undergoing a surgical, mainly cardiac surgery and spine surgery and prosthetic joint. This is clear evidence that's decolonization, and there is a protocol for that before those kind of surgeries. But for ICUs, it's there is debate about it. If your aim is to prevent invasive infections, MRSA, bacteremia, there is some evidence. It says yes, going with targeted rather than universal decolonizations. But again, you need to pay attention for emerging resistance against mupirocin if you are doing universal. But I'm with targeted decolonizations of any MRSA carriers in the ICUs with mupirocin ointment and chlorhexidine gluconate bath, which is for like 5 days, or as long as the patient in the ICU.
I agree with Dr. Faisal. I mean, there had to be a targeted for certain population, but not as a routine.
Thank you. I'll go to the next question because it may be related. Daily bathing with chlorhexidine impregnated washcloth is indicated in all inpatients, high risk like ICU patients, or none? Dr. Ali?
I think it's a good answer that it's a high-risk population in the ICU. Doing it for all inpatient, it might harm more. It also might increase the resistance, and they also might predispose to patient being accepting new organisms when they are being bathed daily basis.
So I notice all the questions raised is considered to be an unresolved issue sometimes, especially chlorhexidine bathing outside the ICU. If we say all inpatient, that we consider like in the answer like pediatric patient below 2 months in ICU and pediatric ICU. I'm not sure if the latest recommendation by the CDC and CHE guidelines, they released few months recommendations for chlorhexidine bathing in pediatric, but what I know, it's below 2 months. It shouldn't be used in ICU because it can cause skin irritations. Chlorhexidine bathing is in ICU and high-risk patients. High-risk patients outside the ICU, like oncology patients, hematology patients, yes, because they have most of the time they have lines. So we are routinely applying chlorhexidine bathing in ICU patient and high-risk patient outside ICU.
Thank you. Anyone from the audience wants to share his opinion? Dr. Majid? There.
So chlorhexidine body bathing, it showed their effectiveness mainly with the gram positives more than gram negatives. There are few data on gram negatives, some of them showing that it has a great impact. Others they're saying that it will emerge certain things and also chlorhexidine resistance. So there is a lot of debate about them. So selecting criteria for patients like ICU, National Guard, we're doing all ICUs. And certain patients with high risk, as our colleague mentioned, but I will add to them pre-procedures, like things that may access vascular system, let's say putting a line or cardiovascular surgeries and other things. We pre-surgery just the night before and the day just before the procedures, it's been recommended.
What about long-term care patients, Dr. Majid?
Long-term patients also, but again, it's not as much. But some of recommendations, and it was actually before long time ago, that they bath the patients when they come to the hospital first and upon discharge, and also it's very effective, especially if it's short-term kind of admission. It's been a recommendation long time ago. Even in our hospital, when we introduced the chlorhexidine body bathing, they're saying we were doing it long time ago on admissions and just before discharge. And it's again very selective and less burden and acceptable.
Dr. Zain, if you allow me, for one
yes,
point.
sure.
Some ICU patients, they have who are in the lines, who are getting lines, the line is covered by chlorhexidine impregnated dressing. So the questions, are you using bathing for them or just this is enough, the chlorhexidine impregnated dressing? So it's used for prevention of bloodstream infection, invasive bloodstream infections, and it's used for decolonization. So the patient can be colonized in the groin and other areas. So it should be used, the chlorhexidine bath, while the patient is getting this dressing. And the other point raised by Dr. Ali about the concentration of the chlorhexidine, we see now it's more than 2%, like 4%. So which one we use? All the evidence is going with 2%. I don't think there is any additional benefit more than 2%, unless Dr. Ali is. So Dr. Ali is agreeing that 2% is, as per evidence, is more than enough.
Okay, we'll go to the last question. In your opinion, what's the most important factor to prevent infections in the ICU? Hand hygiene, PPE adherence, environmental cleaning, single rooms, cohorting patients, increasing staff-patient ratio like 1:1, staff and equipment dedication, no sharing. Hand hygiene is dominating. I think each one has a weight. It has a significant weight. What do you think, Dr. Ali?
I think hand hygiene is the most important thing. I mean, us as a transferring the organism from one place to another, from the environment to the patient, from the other patient to the other, from the healthcare worker to the patient, it's the most important, and it's the most thing that we do for the patient, i.e. we touch the patient, we touch the what do you call it, the instrument around the patient. I think it's the hand hygiene the most important.
For sure, hand hygiene is the most important. Again, the average reported rate is 40% all over. We need to stress on the importance of hand hygiene. The other thing that we are ignoring is environmental cleaning. Environmental cleaning has been touched by Dr. Salma in her lecture. It's very important. If you have dirty environments, your hands will be not clean by touching this environment. So make sure that the housekeeping, the company there, they know what they do, because in our routine work we just saw some like of housekeeper. They use the same mop or the same cleaning materials from patient to patient. They are not changing. So again, all of these are very important. Environmental cleaning we shouldn't ignore it. Environmental cleaning can be done by nurses. Any equipment in ICU, it's the duty of nurses. There is usually conflict between the company that's housekeeping and the nurses who gonna clean the equipment. It's sensitive machines, so it is by policy in each hospital. It's duty of nurses. It should be cleaned like there is a routine cleaning, like with each shift, like twice per day. If there is any increase in endemic rate of infections or outbreak, this need to be, they need to add another like 3 times per day. So it's again, but hand hygiene is very important. It's the most important measure or strategy. Thank you.
Any other thoughts from the audience? Dr. Yamin, please.
I have a comment. Maybe I am supporting the nurses more. What we are facing when we are increasing the nurse ratio, I'm thinking the hand hygiene will be solved, the PPE adherence will be solved, everything will be solved. Universal ratio of the nursing across all hospitals, we have a problem with it. I think if we solve it, it is important hygiene, it is important, as Dr. Faisal, environmental. Nursing ratio, it is very important. Once we solve it, I think we'll solve the others easily.
I think Dr. Yamin also not only the nursing ratio, the nurses needs assistance, needs help to handle the patients. So these also has to be dedicated for patient not to share the patients. And Dr. Majid, I need your thoughts in dedicating equipment, dedicating staff. How applicable is that? Like ultrasound, thermometer, for example, vital signs. Is it cost effective, applicable? What's your thought on that?
I will answer you, Doctora, but maybe I'll go first talking about hand hygiene, and then we'll go to your questions after, and how to look at it in a bigger picture to understand the emergence of infections or resistance in the hospital. It's actually have two parts. The first part is infection control, transmission of infection from patient to patient or from environment to patients. The second part, pressure of antimicrobials in the hospital. So you have to control both in general. Hand hygiene is the most important, and most easy to implement and most important to prevent, at least the part of, transmission. So it's the most single interventions that showed effectiveness and easy to be implemented. But not alone. You have to do more than things. And people, they start talking about, bundle of care, specifically for preventing emergence of infection within the hospital. So hand hygiene with environmental cleaning, with stewardship, decrease the pressure of antimicrobial in the units. All together, they bundle them to have, decolonizations, to have a better, interventions. To your point now, which is equipments, sharing equipments within hospital, they have to have a standard of cleaning and disinfections, and as much as we can, we should, try to avoid it. Just to remind you, with Candida auris now, it's around and it has an issue with most of disinfectant that we are using, and so if you have a patient with high risk to have a Candida auris or known to be Candida auris, we have to dedicate equipment for them, and you have to use a specific or special kind of disinfection that will kill the spore, and will kill Candida auris, that APA approved for Candida auris. So again, it's an issue. Still, we are sharing equipments. You have to clean them and put a policy for it for disinfections. And with current, prevalence of Candida auris, you have to ensure that whatever disinfectant you are using, it's can kill spores and also can kill Candida auris. Thank you very much.
Excellent. With this, I will conclude just for the sake of the time. Thank you very much, Dr. Ali, Dr. Faisal, everyone, for your rich discussion. Now we'll go with the recognition. Dr. Ali, would you please go on the stage for the recognition? Dr. Faisal as well.
دكتور علي البراك. دكتور فيصل الأسمري. and دكتورة زينب الموسى. share with Dr. Zainab Al-Musa the next session. The next session title Maintaining a Safe Environment Care in the ICU. And in this session, we'll discuss clean care and safe care and designing an ICU in era of infectious disease, environmental culture in the ICU. So Dr. Zainab, Dr. Fadl, the floor is yours.
Assalamu alaikum. I would like to welcome you for this session. Thanks for joining us. I'd like to welcome to the stage Dr. Samia Al-Nasri, infection control practitioner and supervisor at Imam Abdurrahman bin Faisal University. Dr. Al-Nasri has experience of more than 15 years in the field of infection control. She participated in different research related to infection prevention and control. Also, she is a surveyor for infection prevention and control standards.
Good morning, everyone. Assalamu alaikum. Thank you very much for the organizing committee for inviting me for such activity. It's my pleasure to be here. Actually, I was happy when Dr. Salma and other colleague explained the infection control standards. Then I thought that my job gonna be easy. But with the last question that was done by Dr. Zainab in the poll, when I saw that the environmental cleanliness had got 0 score, I realized that my job get difficult. So I'll try with my presentation. I don't know if there's a chance to repeat that poll after my presentation, at least to feel very assured. Okay, so I'll talk basically about how to maintain a safe environment in the ICU with all those complicated patients, all those complicated procedures we are conducting to our patient to maintain their life. Okay, so we will just speak briefly about ICU and the risk factor for healthcare-associated infection in the ICU. The infection control standards like hand hygiene, use of PPE, patient isolation, but we will focus more on the care of equipment and environment. So usually the intensive care unit serve patients with severe or life-threatening illnesses and injury that require constant care, close supervision from life support equipment, medication in order to ensure normal body function. So basically, this is how does ICUs look like, a patient critically ill with multiple equipment, procedures, so many teams attending those patients. So you can imagine how much this patient had in contact with the healthcare workers, and he had contact with patient surrounding items like all of those equipment and all the different teams they are getting in touch with this patient. So as it has been discussed earlier, the rate of healthcare-associated infection is higher in the intensive care unit than the other general hospital population, and that's mainly due to the unique environment where the most severely ill patients are brought together in one unit, whether they are in one room, separated by curtains, or individually room. And those type of patients, they are really chronically ill, extreme ages, having multiple procedures like a trauma patient, and patient with unknown history sometime, like an emergency situation. So the risk factor for healthcare-associated infection, I can classify it to patient care related and not patient care related. So if we go to the patient care related risk factor, it's either the use of the invasive device to the patient like ventilators, central line, catheters, endotracheal tubes, the amount of patient care contact in the ICU environment, and the antimicrobial use and its impact, as it has been discussed earlier, with the multi-drug resistance that may cause an outbreaks and make the situation more challenging. For the non-patients care related, which is a staffing issue, I think it has been also discussed earlier, like shortage of staff, it is one of the major elements that lead to increase of hospital-acquired infection, inappropriate training or implementation and compliance to infection control standards like hand hygiene, isolation precaution, and PPE. of course, environmental contamination as well. So in order to achieve a sustainable reduction in the healthcare-associated infection in the ICU, there is no single action that can be done will guarantee for this, but support, commitment, and engagement of all healthcare workers, both clinical and non-clinical, in the following of infection control standards are essential to reduce the healthcare-associated infection. So this has been repeatedly discussed, but I will just focus on the things that we are observing that lead to contamination of our environment in the hospital. So if we go back to the hand hygiene, everybody is well known about the 5 moments of hand hygiene. This is an approach that was already established by WHO, and I think most of the hospitals, they are using this approach either to observe their staff, to measure the compliance. But when you go as an infection control practitioner, something about the data collection, to avoid the use of bias, changing time, it may help you, but try to use volunteer. People, they, unfamiliar. They can go and audit, train them, let them audit the unit, so we'll have a real picture of the hand hygiene data. Now, from my experience, when I look at our hand hygiene data and we investigate why it's low, we measure each moment and we find out that we have low compliance with the hand hygiene in moment number 1, which is before touching patient, and moment 5, which is after touching patient surrounding. We investigated more because we believe that no healthcare worker is a negligence or he want to cause harm to patient. But when we investigated more, we found out that healthcare workers believe once they wear those PPE, they are safe. So they don't think about the risk, whether those PPE can be contaminated or how those things can be contaminated and will affect patient care. So once they will wear the gloves, they will feel fine. Okay, they don't need to do hand hygiene before wearing gloves because they wear gloves and they go to the patient directly. In fact, if you go back to the infection control standards, it says hand hygiene, wearing gloves, and go to the patient, okay? That's if a gloves is indicated. So this caused the low compliance in moment number 1. Another reason for the low compliance in this moment, people, they don't do it right. So it says here before touching patient. What we see in the clinical practice, they do the hand hygiene, they open doors, then they touch the patient. So here they again, they cause contamination of the hand. So the moment says it's before touching patient, okay? So that's why we always ask the help from our administration for the dispenser distribution. Though it may cause more cost, but there will be a reflection later on the infection rate because we need those dispensers to be easily accessible, ready to be used everywhere. We don't need the staff to look, where is the dispenser, okay? At least to overcome the low compliance in this moment. Now, in the moment 5, after touching patient surrounding, when we investigate the reason why people, they don't really clean their hand after touching patient surrounding, and I can say here, they don't see those patient surrounding as a risk factor for infection. They usually focus on a patient himself. Though when I will come later on in the lecture, you will find, hopefully that I will give you the message and how to convince also your staff to clean their hand after touching patient surrounding. Just take note of some of those messages to avoid contamination, and my lecture will focus more on preventing contamination to the environment to make it more safer. So don't add soap to a partially empty soap dispenser. Try to stop this practice in your hospital because this will lead to the bacterial contamination of the soap, okay? So every time it's a new dispenser, okay? And as I said, provide the healthcare worker with a ready accessible alcohol-based hand rub. Now, if you go to the procedure of hand rub and hand wash, it's easy, it's the same. There is only minor things change, where hand rub, you need to use the alcohol hand sanitizer, while the hand washing is using soap and water. Again, during our practical round and our practical daily observation, I will tell you with the mistakes that staff are doing, and of course this is not intentionally, because I believe that there is no healthcare worker want to cause harm. So if you are doing the hand rub, remember you will apply it. I recommend that all hospitals will post those posters in front of each dispenser or hand washing sink. So staff, they will be reminded about the steps so they will not forget anything. In your education, focus more on the technique and let them ensure that the alcohol hand drops, I mean, they will not do magic without an effort. So they have to do the technique correctly, friction, and they have to allow it to dry by itself with the friction. The mistakes they do, unfortunately, sometimes they wipe them off, okay, or they dry them, or they, sometimes they wash again. You know, after the hand rub, they do and they wash again. So whenever you are applying hand sanitizer, alcohol, put the right amount and continue the process, the friction, until the alcohol hand rub is totally dry by itself, okay? This is how it's gonna be effective. For the hand washing, as I said, it needs soap and water, and the mistake happened there usually when the staff, they are doing the hand washing, they will put the soap and then they will put the water. So half of the soap will run with the water. They don't have enough soap to cover their hands. Or another mistake is after doing the whole procedure, they will close the faucet with their clean hand. And again, this is wrong because they have opened the faucet with their dirty hand. So just take a note of those mistakes and try to educate your staff so they will be enlightened more about the risk behavior they are putting themselves in. Okay, the using of PPE, of course, I will speak a little bit more here because I can see that there's three types of isolation, as we know, which is contact, airborne, and droplet. And there is something we call standard precaution. And there was an earlier discussion about the universal wearing of PPE and everything, and we all know now that it's not recommended. So please be reminded and reassure your staff that standard precaution, it means the universal, but in a way of logic thinking. So usually what we recommend for the standard precaution, because we say do standard precaution for all patients, regardless of their diagnosis. So the staff will be confused. What do you mean by standard precaution? So the standard precaution is choose the PPE according to the risk or the procedure you are doing. And this is how you're gonna be protected. Example, if you are doing blood extraction, as a standard precaution, you will wear gloves. So you will assess the risk. What is my risk? I'm gonna expose to a splash. Okay, then wear mask and eye goggle. Am I going to do a dressing for a big wound? I might contaminate my clothes, so then I have to put the gown, gloves, and so you have to be familiar with the risk that you are exposed to with your patient. And based on that, you will decide to use your PPE. That's why standard precaution, I believe it's more difficult than the other isolation precaution, because you are the decision maker. You are the assessor on what to do and what you need to wear, okay? While in isolation precaution, it's easy. The poster is there on the door. You will read it, just 2 minutes to read it. You will follow the instruction there and you will go to the patient, right? And that's why it's more easier than the standard precaution, okay? But again, put in your mind that those isolation precaution is always with the standard precaution. An example, if you are going to a patient with MRSA, the contact precaution sign doesn't require you to wear mask all the time. Though now, because of COVID, we are wearing masks, but regularly, if you are entering a patient with MRSA, you don't need to wear mask all the time. But remember, because of the standard precaution, if you will do suctioning to that patient, you have to wear mask, okay? So this is how we be a cost-effective in infection control and how we manage things effectively. And not just to waste our resources, then we will end up of having nothing with our patients, okay? So going back to the PPE and mistakes that may contaminate our environment is when we are removing or wearing those PPE, pay attention to the way we are wearing our gown, and the mask should cover nose and mouth. The gloves should be over your gown. And when you remove those PPE, try to remove it from the cleanest part, because you don't want to contaminate yourself. You don't want to contaminate the hospital environment, okay? So it's from the back side, fold it in, then also the mask from the back, then don't manipulate, throw immediately, and of course, hand hygiene will be, is recommended between steps. Okay, so try to avoid the behavior that may contaminate yourself, your clothes, or the hospital environment. For the patient isolation, which is using positive and negative pressure, it is there. Again, be careful because some hospitals, they use rooms with the two type of isolation, so they can just convert it from positive to negative. So the nurse, they have to be more attention. Whenever they are admitting patient to a negative, they have to check that the monitor is really on the negative pressure. It's according to the standard, and this is to avoid the contamination of the hospital environment. Now, care of equipment and environmental cleanliness. A clean environment, of course, provide the background for good standard of hygiene, as well as maintaining patient, staff, and visitor confidence. And we consider the ICU environment as a high-risk area. So if you look at the role of the environment in healthcare-associated infection, there is 2 recent studies demonstrate that contact with the environment was just likely to contaminate the hand of healthcare worker as a direct contact with the patient. Okay? So this may change your opinion about the environmental cleanliness. And as we know, the microorganisms are there everywhere, and they are most common nosocomial pathogen may will survive and persist in our environment for a long time if there will be no regular cleaning and no effective cleaning and disinfection. And this, I just gave you an example of the common bacteria that that may survive for long in our hospital environment. If you look at the Acinetobacter baumannii, it will last from 3 days up to 5 months alive, multiplying on your equipment, on your surfaces, if you don't really clean them effectively. If you look at the Clostridium difficile, they may survive up to 5 months. If you look at the E. coli, it's from 1.5 hours to 16 months. So if you are in a hospital, you may go on vacation and come back, and that E. coli is still there on that equipment. Okay, that's why we have really to focus on our hospital environment, on the medical equipment we are using with our patient. The Klebsiella species, they may last 2 hours to 30 months. Pseudomonas from 6 hours to 16 months. So it's really a long period of time. They don't die easily. You got my point? They don't die just like that. I mean, if you look at the viral, it's different. They don't behave like bacteria. They die faster. But we are really in a situation where we have a long survival for the microorganism. So if you are providing those protocols for the cleaning and disinfection for your medical equipment and hospital environment, put in your mind the highly touchable surfaces or the frequently touched surfaces. Sometimes these are not within the patient care area, but they are considered as a risk environment. It is the area highlighted with the red dots. You can see the bedside table, the pillow, the monitors, the telephone, the call bell, door handle, light switch. All of those surfaces need to be cleaned regularly, every shift, twice a shift. So it has to be considered with the daily cleaning and disinfection. The toilet, the bed band, the commodes, in the station, in the nursing station, the computers, patient's file, telephones, a chair itself, the portable equipment like portable computer, portable machine, portable ultrasound, borrowed items from different hospital units. All of this, you have to consider their contamination and the possibility of those contamination to cause outbreak in your unit. Okay? Also in the corridor, the hallway, the wheelchair, the patient bed during transport also. Okay? After talking about the survival of those microorganisms and where they located, the mainly induced high-touch surfaces, we have also to consider the construction and the design of our ICU and the spacing between the bed. And this has been, a new document has been reviewed from 1866 to 2008, found that the recommendation for bed space had widths increased from 2.4 meter, and now they are recommended 3.6 meter. Okay, if not, and this will allow the easy traffic and all those medical equipment connected to patient, and to have an easier way to clean them and disinfect them. Again, remember your furniture in your clinical area should be made of a material that is cleanable, easily to clean, okay? And suitable area should be designated for safe storage of equipment and supply to avoid contamination. And believe me, this is very important because during my year of experience, I have visited a store where a clean and contaminated item are together, and when we do like an outbreak investigation, I randomly culture the clean, and they were contaminated with the same growth of the non-cleaned item. So you have to really focus on the storage in your area. Now, if we go back to the equipment of a patient, it's a little bit complicated than the environment because we have like single-use item, we have the reusable item. So remember those standards. So handle used equipment soiled with blood and body fluid, secretion or excretion in a manner that prevents skin and mucous membrane exposure or clothing contamination. Ensure that the reusable item is not to be used for care for another patient unless it has been processed, cleaned, and disinfected appropriately. Ensure that single-use items are really single-use and will not be reused. So just to remind you the definition of cleaning and disinfection and sterilization definition. Cleaning means the removal of organic material on a surface. Disinfection refers to the elimination of many or most microorganisms, and sterilization refers to the complete elimination of all forms of microbial life. And this is usually through a physical or chemical.
4 minutes, Doctor.
4 minutes? طيب. The classification, طيب, since it's 4 minutes and still I have some more slides important, I recommend all of you, if you are involved in a medical cleaning and disinfection in your area, go to the guideline in ABIC. It's done by William Rotala. If you can just document it. It describes to you every item, how do you classify it, how do you process it, and what kind of hospital-approved disinfectant you should use. And again, as was mentioned before, the responsibility of cleaning should be listed clearly, should not just be left like that. If you have, I'm sure if I will do like a poll now on who is cleaning those items, I will find different answers. But I will not give you the answer. I will let you to go back to your organization, sit together with your infection control, with your administration, with the nursing, and list down all your medical equipment and try to do a policy that define each medical equipment, who is responsible of cleaning it, and what item you are going to use, what type of chemical you are going to be used for that equipment, and how frequent you will clean those equipment. Is it after use? Is it single use? If it's twice daily? So you have to make sure to have this in your policy clearly. This is a very useful tool. It will protect all the nurses or housekeeping from the conflict that's happening between them. Now, this is a very interesting topic, specifically for those who are participating in the selecting of type of disinfection, because again, we are aiming to reduce the contamination effectively in our hospital surface, so we have to select our product carefully. Whenever you have a disinfectant in your hospital and you are decided to select to approve it or not, consider the kill claim. Is this disinfectant useful for your organism? What you are fighting in your hospital? The contact time. Of course, you will not choose a product that may last for 10 minutes or half an hour, okay? Because this will increase the time or waiting time for the next patient to come to the room. The safety of this product. Is it flammable? Is it toxic? Is it compatible with your surface? Again, compatibility is important because administration will call you back whenever the medical item is damaged, specifically the monitors. We have seen a lot of ruined medical monitors just because staff are wiping them with alcohol. So you have to be careful when you are choosing or selecting your medical, your disinfection for the medical equipment. The easiness of use of this product. Is it easy? How much PPE is required? The discard of those product. Does the supplier give a training for your staff on how to use this? This is very important. And believe me, since I was involved in infection control and product evaluation, I have rejected so many products just because the label was in German, okay? So it is in a language that is not understood. So totally I reject without looking at any ingredient of that chemical. So you have to be wise when you are selecting dose disinfection. And of course, the efficacy of dose disinfection is affected by so many factors, like the surface before cleaning, whether this disinfectant is detergent and disinfection or only disinfection, I mean, it was not cleaned before, the insufficient training to the staff, or confusion between the nursing or housekeeping responsibility on who is cleaning what. Again, in infection control, it's not enough to clean and disinfect and go away. What we do usually, we inspect, we monitor everything. And this is the method where where it's recommended on how to inspect the cleaning and disinfection. So the visual inspection, like the checklist. This is a simple, inexpensive, but this is not a reliable measure, okay? Some people also, they use label on equipment that this is clean. So again, this is not a reliable. Some of the hospital, they use the culture, the colony, the culturing. Now this is simple, but this is of course expensive. It costs a lot of human resources like the lab, plates, swab, and affect by the way how you are collecting this. I personally don't recommend this type of monitor. There is also the fluorescent marker system, where the infection control or any representative, they can leave marks and surfaces, and in the next shift, they go and they inspect whether those has been erased or not. This is required the use of UV light, and I find this more friendly. But it doesn't give you what are the organisms there, okay? It just gives you that this area has been cleaned, and sometimes it's difficult because I'm looking at the mark. Where did I put it? Okay, if I don't really take a note of it. Also, there is a tool in the market, the ATB-SA system. It provides quantitative measure of the cleanliness. It gives you a quick result, and it will, of course, improve the practice. All of them will improve the practice, but it's more expensive. You will need to purchase a lot of the luminometers and the swabs in order to implement this.
Time, Doctor.
Time? Okay. Now, because we know that routine cleaning is suboptimal, there is a new technology has been there for to enhance the cleaning and disinfection, like the using of UV light, the vapors of chemicals like hydrogen peroxide, the antimicrobial surfaces. Yes, there is some studies discussing that those will reduce the colony of the microorganism, but still more study is needed to see the impact of the healthcare-associated infection with using this, though we recommend to use such technology as a terminal cleaning in some situation. So in a summary, I would like to just summarize it with this message that none of us is as smart as all of us. So again, commitment and collaboration from all the surfaces will improve the care to our patients, specifically in the ICU. Thank you very much.
Dr. Samia's impressive presentation. I would like to invite to the stage our next speaker, Dr. Mohammed Zunaitan. He's a healthcare epidemiologist, consultant of internal medicine and infectious diseases, infection prevention and control department at King Abdulaziz Medical City in Riyadh. Dr. Zunaitan is a holder of clinical fellowship in infection prevention and control, and antimicrobial stewardship and clinical fellowship in quality and patient safety from University of Iowa Hospital and Clinics in the United States. Welcome, Dr. Mohammed. The floor is yours.
Thank you, Dr. Zainab, for the introduction, and thanking the organizing committee for the invitation. It's always good to visit AL-AHSA. So, today about the ICU designing in the era of the emerging infectious diseases. So, I was just asking myself, am I going to present something about, I'm not a certified architect, so I'm not going to present something about the specifications, how to design an ICU. But I will just have the touch of the infectious diseases and the hospital epidemiology in this regard. So I'll just give you a background what happened, especially during the last pandemic and the previous pandemic, what the challenge that we have, what the lessons that we learned, some considerations, and we will conclude. So in the last 2 decades, most of the challenges we are having is about the zoonotic disease emergence. So we don't know yet where is the COVID-19 is coming from, but we know it's originated from that. And the others, the pandemics and the outbreaks that we have recently that challenge the critical care capacity are from zoonotic origin, like the MERS. We know it's from camel. So we have always to be very vigilant whenever we are designing our ICU about the possibility of having these emergencies. Not just that, the antimicrobial resistance that we're having is the current pandemic. It's the one challenging every single resource that we have. So whenever we're talking about the emerging infectious diseases, we just see the burden and the growing need of the critical care. So SARS outbreak have to have 32% of people who's having SARS within the healthcare facility needing the critical care. While about the MERS, and it's the highest, we had to have about 60% from people who's admitted with MERS requiring ICU. And I know one of the facilities, and especially our facility, we're mandating ICU admission for every MERS that recently diagnosed because of the high mortality rate. While COVID-19, and we always having this pandemic, and we're just really aware about the stress that happened at the beginning of the pandemic, and that's reported from the early on, and now decreasing the disease severity is decreasing. So, as you can see here in the graph, that's the last 2 decades that the major outbreaks that happen and the pandemics. So most of them, as you can see, they are zoonotic, but the diseases they have, the pandemic capabilities are respiratory in origin, and they cause respiratory. And the problem with the respiratory diseases is going to be very difficult to control them once they are into the healthcare organizations. So, but we should always be aware about the risk that the non-respiratory emerging diseases like the dengue fever that might have within the Ebola, the Nipah virus, the Marburg viruses, these hemorrhagic fever that when they have very potential risk to spread and cannot be controlled within the critical care units that we're having in our hospital. So I believe this is the, can we shift the slides? This is the old one. Can we change the new slide? Sorry. So I will talk about the current recommendation that we're having designing our ICUs. So we're having our reference whenever we're trying to give any recommendation related to the designing, which is the facility guidelines of SOMEWERE. So now they're recommending in the 2018 that if you are designing an ICU, each patient should have a single room, and they are giving us the minimum clear floor area to have to be within 200 square feet, which is approximately 9-ish meters square, and they have to have a hand washing station in each room and a toilet separated over each room. So when it's come to the airborne infection isolation, sorry, moving a lot. Sorry about that. So when it's coming to the airborne infection isolation, as what they are recommending is to have at least one in each unit, but we need to update the need according to the ICRA, the infection control reassessment, into how much we need rooms into our units. So the ASHRI and the ACHI about the HVAC requirement, as you can see, that's the published requirement. They don't require the pressure to be fresh to the units of the ICU, and they're just having the regular inpatient recommendation just moved out to the ICU. That's the general recommendation. So what about our local recommendation? If you can see the Ministry of Health recommendation, they're almost similar. Now they are adding now the possibility of having the multiple bed space, but they have to be at least 130 square feet, which is almost like 200, but they minimize the square feet, the square meters, when it's for the single room. They still requiring the hand washing stations to be placed in the nursing station, not in every single room, and they have to have at least one hands-free, and they should be located near the entrance of the patient cubicle if it's multiple beds. But when it's come to the airborne infection isolation rooms, the recommendation is IC should at least have one airborne infection isolation room for each 8 beds. So the problem is, sometimes we know that, especially in the very busy tertiary care centers, the requirement can be more than that. But that's the general recommendation from the Ministry of Health in this regard. So now we're moving about the challenges that we are having. So COVID-19 just told us about the massive need to upgrade the surge, to upgrade the ICU to accommodate the surge and to have the surge capacity. So we're having now 2 challenges. It's about whenever we're having a pandemic that's hitting us or an emerging infectious disease that's hitting us, we're having to expand the need for the regular beds and also to accommodate these patients that having and requiring the airborne infection isolation. So always we need to keep in mind how we can accommodate this surge. And the second need that we need also to consider, and it is challenging, is whenever we're having, for example, someone who's coming with Ebola, just visited us, with suspected Ebola, coming from the airport, what you would do, and how is the pathway? Do we have a designated pathway from their entrance till they get taken care of that unit? And we always need to see what is the infection control measures that we have to have. Are they up to the standards that we need? And always, 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 when we're talking about the ICU designing, we have to keep in mind the heating, ventilation, and air conditioning standards that we're having in our facility, and the possibility to upgrade them. Yeah, yes. Okay, so sorry for that. So whenever we're, let's go about the surge capacity. So whenever we're designing our ICUs, now the recommendation is to accommodate the surge that we're having. These ICUs have to be in the ground floor. It's easy to reach from the emergencies. They have to be very in great proximity to the emergency departments and to the operation room. We know that the dynamics that happened within these emerging diseases can pose a massive risk to transmit the disease within. And the doubling the ghost beds that within the ICUs have to be established whenever we're having our new ICUs to adapt the increasing in the demand. And also the additional units, what's the possibility of converting other units into the ICU whenever they are needed? Do they have the specifics of the ICU just designed, implemented to be there whenever needed? We can turn out these units. And the implementation of the telemedicine. Telemedicine happened to be very, very effective during the pandemic. And a lot of institutions, they are now having a lot of resources to establish the telemedicine infrastructure within their units just to accommodate the need if another, God forbid, another pandemic happen. So, as you can see, the movement within the care facility is very risky. And this is from the colleagues from the National Guard. This is what happened during 2015 in the outbreak. And this is the dynamics. As you can see, the patients are moving a lot within the facilities until they reach the ICU. That one of the main reasons that these patients keep spreading the disease into a level that this disease cannot be controlled. So a lot of challenges, and this is a question that we receive a lot, is about we're having this patient and this unit, and we want to convert this ICU to be a COVID-19 ICU. So we always have to keep in mind, whenever we're designing these ICUs, to what's the possibility of converting them from the neutral regular one to a negative pressure? And do we convert the whole unit or a part of it? So whenever we're designing an ICU, we need to keep in mind about the HVAC system and how we can fragment this HVAC system so we can handle in each part of the ICU to accommodate the need, the growing need to keep these emerging diseases under control. And sometimes we just dedicate a complete unit to be an airborne isolation unit. One of the great examples that we have is there is like an institution, they invest a lot in building a respiratory care unit. So what's the advantage of having a respiratory care unit or respiratory critical care unit? Is to have the other facility that needed for these respiratory patients with emerging diseases like COVID-19, like MERS, to have the ECMO handy, to have very special HVAC. What happened to the HVAC, as these units will need a very high detailed standards and specific when it's related to the ultraviolet of the ducts are happening, the rotation of the air circulation of the air, it have to be from outside, fresh 100%, and everything to be dumped outside. So now the growing need, while we're having a lot of emerging diseases that sometimes we know and sometimes we don't know, is about having something even beyond the facilities. So an agreement in the European countries and in the United States is to have in each cluster of states or countries to have a high-level isolation unit. So these isolation units, they are for very special pathogens. These pathogens happen to be very highly infectious and life-threatening, and they pose a very serious hazard in the healthcare settings and in the community, and they require very specific control measures, which is what you call high-level isolation. An example is Ebola and smallpox. So as you can see, this is an example of the building in Rome in Italy. As you can see, these rooms are having a door from outside, so they can receive, each individual room can receive the patient from outside, and this patient will be taken care, and these rooms are connected from within. And this is how some of these rooms gonna look like. It's very well equipped by the transfer cabins and how to receive the patients and how to the patient without having the risk. And this is an example of these rooms in the UK. So these units have to be linked with a bio safety level lab, 3 or 4, and they have to have like 6 hours maximum transfer of these. And as we said, it have to be within each territory, within each regional country. And they need to have a very specific and drill every like 6 months or a year, and to have a very specific decontamination areas handling the waste that's happening from these units. So whenever we're designing an ICU, you have to keep in mind a very specific and very intent issues that related to the infection control. So we keep hearing a lot about the advance of the robotics and the robotic cleaning. So how we can use the robotic cleaning and how we can implement the design into the robotic cleaning that they can do regular with a minimum human factor interference. And the use of the ultraviolet. We know the robot of the ultraviolet, that's, we kept it in the room for like 1 and 2 hours. The issue that's related to the ultraviolet is about there is the light-dependent areas that will be cleaned. The shed areas will not be cleaned. So we need also to keep these in mind whenever we're designing it. So also something that we do not think about is about the massive need of the PPE in terms of the crisis, in terms of the outbreak. So whenever we're designing an ICU, we need to keep in mind is can we keep a stockpile and where to keep, and do we have a storage enough to stockpile the PPE within the unit whenever it's needed, or that unit will be isolated like a respiratory unit. The HEPA filters, do we have the HEPA filters? Are they within each room and outside the building? How is the air is handled? Do we need extra units to be implemented within the unit? And always we have to keep in mind, what about the single-use items? How we can use them, the bronchoscopies and the others. So as we can say that the HVAC for the new designing ICUs, whether they are respiratory or non-respiratory, it's now recommended to have them 100 outdoor filtered or IV disinfected air directly to the occupant, and to have the direct exhaust outside. And now the most recommendation is prohibiting the use of recycled air within the ICU. And the WHO recommended that the minimum outdoor airflow rate now would have to be 60 liters per person, and we need to use the ultraviolet germicidal irradiation, the UVGI, as an air cleaner. So what about the other considerations whenever we're designing it? So we need to always keep thinking about the flexibility of the space, how we can move them, how we can upgrade them, and how we can, as we said, the HVAC adjustment. Can we just upgrade it? Can we have the single room now it's using for 2 rooms and now we're having the semi-private and we have the multiple rooms, and always we have to keep this room ready for every thing that we need, like electrical power, medical gases that can accommodate the surge need. And always, now in the critical care, sometimes you can move the patients out, especially in the time of crisis, so there is always the need to have room for the end-of-life and supportive care. So when it's come to the material, we should focus that we don't allow the pathogen to live in them a long time. So the processing, the type of item, the packaging that we use in these units, it have to be very specific, have to be easy to clean and very cost-effective, eco-friendly. So the staff space is very important whenever we are designing an ICU. Sometimes we think about the patient and we think about how we transfer the patient, but we wouldn't think about the staff. So if we are dividing this unit to respiratory and respiratory, do we have a dedicated lounge for respiratory caring staff or not? Are we having enough spaces for them? Otherwise, they will share the other lounges with the other staff from different units, and they will spread the infection within the department. So we need to keep this in mind whenever we are designing our ICUs. So to conclude, designing a new ICU in the era of emerging infectious diseases requires a very comprehensive approach that considers the physical layout of the facilities and infection prevention control measures, training capacity and communication, and we should always learn from the things that happened during the past pandemics whenever we are moving in that. With that, I conclude. Thank you.
Thank you, Dr. Muhammad, for the presentation. Now, I would like to welcome Dr. Samira Al-Johani. She is the head of microbiology and virology. Johani. She's the head of microbiology and virology, Department of Pathology and Laboratory Medicine, and consultant microbiologist in King Abdulaziz Medical City. Dr. Al-Johani is a graduate of King Saud University in Riyadh. Dr. Al-Johani completed her medical microbiology residency at McMaster University, Ontario, Canada. Later, she went on to receive training in advanced virology and molecular fellowship from McMaster University, Toronto Public Health Laboratory, also in Ontario, Canada. She obtained the Fellow of Royal College of Physicians of Canada certification and the American Board of Medical Microbiology. Welcome, Dr. Al-Johani.
Thank you so much. I would really love to thank Al-AHSA Hospital for the invitation and the organizing committee. I'm Dr. Al-Johani. I'm the Director of Microbiology and Virology Lab at National Guard Hospital in Riyadh, and I'm the Editor-in-Chief for Journal of Infection and Public Health. So I will start with, since I joined, my aim was to establish a unique lab, and I had a small video in my lab before I start my lecture. So if we can start the video.
reporting, which is pure infection control. So I have to add few slides from my passion, which is a new diagnostic and new modalities for screening of the patients. So as you know, every year there's many lives being taken because of spread of infection, mainly in the hospital. Healthcare worker usually taking a lot of steps to prevent the infection, but still it's happening with a lot of multi-drug resistant organism. That is a main topic of the day. So identifying the hazard could be potential compromise some of the patient care. And you remember in each hospital there is an area of renovation, demolition, and construction activities that I think it's a nightmare of an infection and prevention and control team. And these projects is always associated with a lot of environmental testing and screening and cleaning for the air, for the water, for the utility and equipments. And always remember, it's not only the patients, even the healthcare workers are exposed to a lot of potential hazards in their workplace, and that's why I think the main theme of this session is infection control and abet with the standard of infection control and the hand hygiene. It's not only for the patients, it's also for the healthcare workers. I'll talk about a unique outbreak that happened in our ICU last year, the year before, in 2021. And a total of 51 patient or case was diagnosed with Burkholderia contaminants. And at that time, the infection control was alerted when we start to have 3 samples within the few days, all with this unusual organisms from different ICUs. And as you expected, the outbreak management started, the active surveillance started, a lot of environmental samples start to be obtained, and we start to monitor and report all the clinical cases. All the cases were respiratory samples, tracheal aspirate and sputum. 5 of those samples is from blood. And I'm not sure if anybody has similar situation, because I do assume other hospitals do have the same because of the source. It took us a while, to be honest with you. They sent us everything you could imagine. The tubes, the surface from all different rooms in the ICU, the water from the sink, from the staff, we start to get from drugs, medication, IV fluids, and all were negative. And this is an example of a lot of area need to be screened and swabbed to ensure from where is the source. They start to shift to mainly IV fluids and medication side, mainly because of the pathogen itself, as well as it's a different ICU, so it's not all in the same area. So there was one sample start to be positive, which is from the mouthwash. And I tried to hide the name, but and they start to get us different bottles. We found it in few of them, so it was in that wash to prevent ventilator-associated pneumonia. And that was the end of that outbreak during 2021. Burkholderia contaminants is a gram-negative aerobic non-sporulating bacteria previously isolated from water, soil, animal, and contaminated pharmaceutical product. Then 2022, we had the same one, June 2022. This time, infection control immediately focused on the same source, though it's from a different company, but honestly speaking, it's the same mouthwash material. It was 16 patients at the second outbreak, 3 from blood, 1 urine, and the rest respiratory samples. So the ICU environment is very complicated. There's so many equipments, and if you look at one room, there's so many materials, equipments, IV fluid, bed, and I know they stopped the bed, the pillows because of the corona, but I mean, so many materials and equipments within the small room that need to be cultured. Before 1970, the US hospital, usually they were conducting a regular environmental surface, floor, water, tap waters, and tubes for screening, which was routine. Then Then in the 1970, after that, before, since 1970, CDC stopped that practice, and they did not recommend or advocate toward using it because they mentioned that there will be a lot of materials that you don't need, and it will be a lot of data you cannot interpret. Between 1970 and 75, 25% of the US hospital reduced the extent of that routine, and nowadays it's almost nil. There is a clear force situation that you have to do environmental testing. Environmental, talking about the surface, the intimate surface, the water, the air. And the fourth situation, mainly the outbreak, for outbreak management. And I'm sure everybody in this room has been involved with such practice at one point in their practice. You have to have a clear data, and very important, even the sample, and I refuse to receive it unless it's very clearly labeled from where and what time did collect, because the time would make a difference. If they collect it in the morning and they send it to you late in the afternoon, you may lose some of the material. And it's very important, whenever you have an organism in your ICU environment or the hospital environment and you have patients, you have at the end of this outbreak, you have to think of linking them together. Are they similar or not? Pseudomonas aeruginosa from the wall of the ICU, is it the same from the patient respiratory sample or blood? You have to link them together. The first step as a microbiologist, usually we are looking at the antibiogram data, and sometimes we are looking for a specific gene within our phenotypic detection materials. The second, which is in case of research. So sometimes you want to do a research pre-cleaning, post-cleaning for specific material, or you want to look for any research project that looking at what's the environment in the ICU look like. So this is a second example people are doing the environmental testing. The third, which is monitor a potentially hazard environmental condition. And that sometimes you will see it in very old ICU, or if you see occasional unusual pathogens, sometimes they are doing this. And it has to be in agreement with infection prevention and control. The last, which is for quality assurance, and we're still doing this before opening any OR or opening a new ward. Usually we have to clear the environment of that new ward or new, and recently we have this cash hospital, which is the children's hospital. We had to clear the environment, mainly in the ICU, before they start to use it for patient bedding and patient care. So there is a biological monitor for standardization process where we use bacterial spores, and that we are using also in our lab environment. And the monthly culture of water, the hemodialysis water, we still do culture and ensure its safety. Periodic testing, some of the experts in the US, they advocate for periodic environmental testing to evaluate the microbial particulate quality. And there is certain equipments in healthcare setting, like the biological safety cabinet, in our lab and in the pharmacy. Very important in the pharmacy because they are preparing drugs and give it to the patient. And just yesterday, there was a discussion about when they are separating the component in the blood bank, that biological safety cabinet also need to be, because not all the hospitals are doing that, but that biological safety cabinet need to be monitored very closely because you are giving the blood to the patient. So the type, it's either air, water, or surface, and I'm not going through a lot. The air sampling, there is different technique. There's people who's opening the plate and looking at, there's around 5 different methods, looking for precipitation, or we have this specific agar-based material where you put it for the air to monitoring it, you keep it overnight. You can have an equipment that collects the air and concentrate it, and you use it on the media. So I'm not going through a detailed microbiology, but there's filtration, centrifugation, electrostatic or thermal precipitation, all different methods available, mainly for the air, as I mentioned, prior to using any words. So how can microbiology help? We have to have a strong relationship between infection prevention control for early monitoring, early reporting of unusual pathogen, especially when we see it's happening so frequently, and supporting them to identify any new cases. Setting up a surveillance program is very important. MRSA, VRE, C. diff, MDROs, and Candida auris. And I have to talk about the Candida auris because it's a major issue, and we have a big surveillance program at the National Guard. And set up the microbiological tool to detect these pathogens. So early detection and reporting, very critical to help you to pick up these cases, because at the end of the day, what we really care about is the patient care, and as long as we early detecting the pathogen in them, we can then be able to look at any break in the infection control practice. So the lab surveillance, which is, I'm sure everybody are using a screening program for the infection control, the surveillance program, MRSA, VRE, C. diff, and MDROs. The main mode of testing in most of the hospital, not all, is molecular based or chromogenic media, and both of them are good enough. We are going with the molecular because it's fast and rapid. As you see in the video, we have the Infinity Gene Expert, the big machine, because of the capacity in our lab is huge. The Gene Expert, when they launch it, they call it PCR for dummies because it's so easy to do. You do not need a lot of expertise. It's just, you have this cartilage, you add your materials and put it in the machine. Then they start to expand. During the COVID outbreak, it was the most important mode for rapid diagnosis of coronavirus. And all the tests on the Gene Expert takes 1 hour, except the TB takes longer. This is the Gene Expert. The second most important test is the CARBA-R, where you have to have a surveillance program looking for the carbapenem resistance. And why I'm talking about this particular one from all the parameters, because talking to people and people calling me asking, I noticed people are not using the test accurately. They are culturing the samples, and whenever there is a positive clip-nemo, they go and check if it is CARBA-R, yes or no, and that's wrong. You have to have, it's a surveillance test, so it's from direct patient sample. So you have to have a rectal swab, and you test it, then you pick it up within 1 hour. Some people are trying to save using the molecular testing, but again, you have to look at your prevalence in your institution. Some institutions, they have higher prevalence of carbapenem resistant than others. And I think that waiting for the culture to grow, you are delaying the result by 2 days. This is our NGA data. So we started since, actually we started since 2014. And I think we are picking a lot of cases as everybody else. Number one is AL-AHSA 48, followed by NDM. But we used to say we do not have KBC in Saudi Arabia. We do have KBC. We start to see cases in 2017, 18. Then nowadays it's getting higher. So we have KBC, and this is the 3 main genes. And MALDI-TOF, the mass spectrometry. People used to say, we don't have a lot of samples, we don't need it, we are depending on phenotypic identification. And honestly speaking, this method is no longer luxury. It's a need, it's a standard of care. You have to have MALDI-TOF for pathogen identification because it won't only identify bacteria, it will identify fungi and mycobacterium. All the rapid mycobacterium can be detected by the MALDI-TOF. And recently we were talking about the Mycobacterium real density, and I'm sure you all have issues with it. This is the only mycobacteria that we look at it, we know it's Mycobacterium real density, but we cannot identify it. There's no biochemical. And the last MALDI-TOF from Bruker, we were able to identify it in our MALDI-TOF. So it's no longer just a luxury, it is a standard of care. It takes 2 minutes to identify any pathogen. So there is something fast, you can help your patient. Sepsis diagnostic, I just finished with the sepsis because this is my topic of interest. Since I joined, I felt we had a few cases that we lost in our institution, and I felt bad, and I started to dig a lot about sepsis diagnostic. So accelerate phenotypic system, it's MIC, it will give you MIC within 7 hours and identification within 1 hour. It's FDA approved, but remember, you have to have a staff working 24 hours, because if they are not working at night and you wait next morning, it will be too late for your patient. We presented that in one of the ID conference in Dubai, and our booster accepted to be presented in the ECMID, inshallah, this year. The main significance reduction in time to report was significant, to be honest with you. It's more than 1.5 days. I like it because it has an MIC data for antibiotic susceptibility testing for the gram-negative. This is the gram-negative panel, and this is the antibiotic that in the panel. I'll move. T2, I'm sure the company will come and talk to you, especially people in the ICU, about T2. T2, it's a direct tube from the patient blood, EDTA tube. You put it on the machine and it will tell you the identification. The issue, I think it's good because I like to have a rapid identification, but the issue with this test, first of all, there is 2 panels, one bacteria, one fungi. So you cannot use both. It's still expensive like all other tests. The second, it has only escape organism, which is the 5 different pathogen, and that's not enough. There is no Acinetobacter because that's done for the US. The US, they do not have issue with Acinetobacter. And honestly speaking, I reject it because of that. Usually when they discuss with you, they will tell you it's direct blood. Maybe that's good, but remember, septic patients, their blood culture turn positive within 2 to 3 hours. So it won't take long time anyway. And this is the machine. I had it in my lab just for evaluation at one point. I'll move. The BioFire, this is the, I'm sure Dr. Mohammed Zinaitan, we were sitting together and talking about the BioFire. BioFire is a multiplex PCR tool. There's a few multiplex PCR equipments available in the market, but this is the famous one because it has 5 FDA-approved panels, and we have it since 2017. We are using all these 5 panels for patient testing, and I'll focus on the blood one. Recently, they introduced the bone and synovial fluid multiplex PCR. So it's for early identification of sepsis. It's called a BCID2. It has 43 targets. It's a huge database. I couldn't put it does not fit in one page. I have to do 2 pages. All of this in one panel takes around 1 hour and 15 minutes. And the nice thing, it has the Candida auris in it, and it has all the CARBA-R, the calcium resistant, the MCR1, and ESBL. The drawback, some of the labs, they do not have simple tool for identification of Candida auris. I've been with them and I see them. They are using this test to confirm a yeast from blood from the ICU if it's Candida auris. The test is about 800 to 900 riyals, so it's not a cheap test. So you have to use it really wisely for sick and septic patients. In clinical practice, because we have the BCID2 and we have the Accelerate, so which is which? Usually we screen with the BCID2 because it's faster. It's around 45 minutes, 50 minutes. Then if we need antibiotic susceptibility testing, we would go for Accelerate. So we will lower the number of tests needed to go for the Accelerate phenotypic because it's around 2,200 Saudi riyal for the Accelerate for one test. So it's relatively, it is expensive. Candida auris, and I'm not sure what people are doing. What usually we do is receive a sample from infection prevention control as per recommendation, and we put it in Sabdex. We wait for a day. You can wait for more than a day, but usually within a day, it will be growing, and we send it for MALDI-TOF for identification. Very easy, straightforward. So hospital environment causative agent for spread of so many organisms, mainly the multi-drug resistant. Clinical lab must be equipped with a tool for a screening of ICU environment and must be working side by side with infection prevention control. The emergence of multi-drug resistant organism, it's very concerning, and it's increasing to a very significant level. Susceptibility testing, very challenging, and we do see a lot of, especially with the oncology world nowadays, very challenging resistant barrier. Effective and rapid communication, very critical and essential between the lab, the infectious disease, and infection prevention and control. Thank you so much.
Thank you, Dr. Samira. I have to say that I'm impressed with the automated microbiology lab. We were both impressed, mashallah. Congratulations. I would invite all the speakers to the stage for questions and answers. Dr. Muhammad and Dr. Samia, please. Dr. Samira as well. Anyone has any questions from the audience, please?
I have a question for Dr. Samira. For the direct culture identification from the blood culture button, have you used the Bruker, utilized the Bruker for this? They have a special kit to use directly from the blood culture buttons. Have you utilized this or evaluated this? You're considering it or?
Yes, at one point I always interested to see what others are doing, but the load in our lab is so huge to the degree, by the way, we have around 30 to 35 positive blood culture a day, so it's a huge number. So we didn't do it yet, maybe in the future, inshallah. I use it only for a specific situation. ICU, cancer patient, oncology, transplant, not everybody, no.
Thank you, Dr. Al-Jahani. Just one question about the environmental samples. As you know, usually during the outbreak, if we think about environmental as a source, sometimes we don't jump first. We think about what's the epidemiological link. And we coordinate with the micro lab if it's okay to get these samples. But most of the time, the yield is almost zero. My question is about collecting the samples. Do you have any recommendations? Do you communicate with environmental departments, infection control? Do you need, for example, ask for swab, for plates, for sponge, the method of the collections? Because what we notice when we get the collections for ICU beds, we are thinking about contaminations. Usually, it's sometimes the yield is zero.
I think this is international, and even when I was in Canada, there is outbreaks that they keep looking for the different environmental samples, and it's all negative. It's most of the time it's negative, yes, and I put that scenario because I was happy it's positive. But sometimes if it's continued, you have to continue monitoring it. Yeah, so it needs time. It needs time. Remember, and sometimes the organism is there, but the swabbing method was not good enough to collect it. And I think I'll just throw a simple example with the COVID testing. And I remember one of my staff, he was sick, he tested himself, was positive. Then he went to the employee health clinic to get an official sample, and that was negative. And he said, I think she took it so fast. So sometime we changed the recommendation. They usually take swab. Sometimes we ask them to put it in a little bit wet swab. Nowadays we are using, if you are using, as you know, if you are using the gel-based swab, it's no longer the recommendation. Everybody nowadays is recommending liquid-based media. So sometimes with that media, try to move things. Sometimes we incubate it for a day to enhance any growth. If there is a major outbreak, I have to look for everything. I don't stop until I get it, but it depends on the situation.
Thank you.
I would like just to add on your comment, Doctora. What we see usually in infection control sometime, if we are collecting sample, sometime people, they forget those samples. They don't send it to the lab immediately. So specifically plates, they will expose it. They think that exposing it more is getting it more, which is wrong. Basically, it's 1 hour and we have to shift it directly to the lab. So also the manner of collection and sending those samples immediately to the lab may affect the result. And
I have a question for Dr. Mohammed. It's an interesting talk about designing hospitals and ICUs, especially in the commissioning phase for building a new hospital. But it's also challenging because we always go with the guideline and the requirement from the infection control, like the ratio of the isolation room, the availability of, for example, the washrooms or the toilets. But it's changing over like 5 years, and you cannot demolish and restructure a hospital again. So especially with the new pandemics and how to design a hospital, what we call is like prepared for the future or future-proof hospitals. What do you think? What shall we keep in mind when we build new hospital, or what to do if regulations change, for example?
Thank you, Dr. Zainab. So that's a very interesting question. First of all, whenever we are designing a hospital, we need to see the scope of that hospital. So what services that the hospital is going to provide. For example, designing an ICU for a secondary hospital is going to be very different from designing an ICU for a very specialized tertiary hospital that would need different scope of services. Like we are blessed in the National Guard to just commission like a year ago the very dedicated respiratory ICU with a state-of-the-art HVAC system that having a very distinct outlet from outside that will handle the patient directly from our flu clinic, which is from the emergency. By that, we just limited the travel that they get within the hospital, and they just go from the flu to the respiratory ICU. Once they clear their course, they will just move in. The second, whenever we are designing the hospital, as I mentioned, the importance of studying the HVAC system of that unit. I can really stress out the importance of the HVAC into spreading the infection and preventing them. The problem is we are just implementing a lot of control measures within the room, but that positive patient is spreading the disease without us knowing to another patient. Sometimes we found that unit, they have their exhaust going into the medical imaging. And whatever in this unit is exhausted directly to this patient is going to come for like an outpatient modality and will get this disease. So understanding the HVAC, sitting together with the frontliner, with our utility and architect about we want this, and this is the scope of the space, how we can design the best HVAC that whenever we need to upgrade the capacity of this unit, just like, okay, we're having this unit gonna be exhausted outside, totally dependent from the other units of the hospital, and we'll have the implementation of the ultraviolet and the state-of-the-art to clean the air within the unit. So, and second is the bathroom and the shared bathroom. I know sometimes whenever we are hit with the cases into these units, the difficulties we're having, they are intubated patients. How are we going to use the bathrooms and etc. That's why it's very important to keep that not just the patients. Sometimes we restrict the visitations, but other non-patients would use this, and we don't want them to go outside the room and spread the infection. So the presence of the room, of the toilet within the room, even if it's not used the patient, is very essential. And we need to put it in consideration whenever designing a new ICU.
Dr. Majid, please.
There's two comments. The first one regarding Dr. Faisal's questions of sampling, environmental sampling. There are special kind of devices for that, and they are very expensive. In general, the recommendation, as you know, we don't use it unless we have an outbreak or sitting and we are just investigating some sort of issues. Otherwise, routine one is not recommended. generally what we are doing from practice point of view, we just use the wound swabs and the red top one, and we put the stick inside the tube and we immerse it with the gel inside. Then we swab the surface and put it back inside. And we have to do multiple in one room to have some general idea, because most of them will come negative. I remember during Candida auris outbreak early on, we used to do this environmental rounds and swabbing different areas, and we ended with 100, maybe thousands even of swabs, and only 2 of them came positive. So the yield is very low. Regarding the questions for ICU's structures, designs, and I agree with Dr. Zenetan, we have to look at the scope early on, involve infection control, environmental health, and engineering, who's specialized in hospital architectures and not civilian ones. So it has to be early on. When things are done, is done, and if new regulation come all the time, you will find there, even in literatures, old hospital what need to do and new hospital what need to do. Generally, let's say now with the air change per hour, the recommendation for old hospital is still 6. For new hospital, they are putting 12 per hour. So you will find 2 options for old hospital, but new hospitals, I think involving people early and design them in the right way is the answer. Thank you very much.
Thank you very much. Dr. Ali.
I agree with Dr. Majid regarding his comment, the latest comment about designing for AI rooms. I have a question regarding the part of the environment is the air. So how frequent we should be doing air sampling, or we should not doing it, and who should be testing for air? Because I mean, these samples for air is very, very peculiar, because it's very difficult to do it, and also very difficult to report it in a right way.
I think I'll move it to Dr. Zenetan. I just received the sample. I'm not sure how frequent they are doing it.
Actually, from infection control program, when we discuss about the airborne sample, because as you said, it's really difficult and needs specific tool to capture the air and to culture it. So we rarely do it, and only in specific situations, like if there's a Legionella case, or if there's like a post-construction concern in a high-risk area. So I think it needs to be considered carefully. It's really not just a routine sample, but needs really a specific tool and specific person who is trained on that tool specifically to do it.
Thank you, Dr. Ali. That was a very practical question. So usually most of the request for air sampling is not really indicated, and that should be guided by the ICRA assessment before we start whatever that we're requiring the air sampling. So, for example, a lot of requests that happen is, for example, they're just moving one tile, and they want to see from the roof if we do air sampling or not. I received a request last week about they're going to change a light bulb, and they want to do air sampling. So we should stick to the ICRA, and most of the requests not really indicating. The problem with the air sampling is the time, because we are doing the very conventional way, is 5 to 7 days to make sure it's negative. And the problem is, for example, I have penicillium, that one colony. Is this positive? Is this negative? What should you do? We lack the standards when it's come to the positive air samples. A lot of technologies that happening, the immunological staining that will be positive within 24 hours, but yet is not yet validated into the practice, or at least for the healthcare. So the short answer is it's extremely depending on the institution. We should not do them routinely. We should always consider the cost effectiveness, because whenever we are requesting air sample, we are blocking the room for 5 to 7 days. That's a lot of cost operationally. So yeah, it's very challenging, and we need to limit the amount that for the most needed and critical care units.
By this we conclude We would like to recognize our speakers.
Thank you for our speaker and moderator for this comprehensive session. Now we'll invite Dr. Samia Nasri for recognition. Dr. Muhammad Zainatan. Dr. Samir Al-Jihani. And our moderator, Dr. Fadil Jaber. We'll have a break now for 1 hour. We'll come back to the workshop at 1:45, inshallah. The first workshop, the antimicrobial stewardship, will be in this hall. The other two workshops will be in the first floor. The screen outside will direct you, inshallah, to the place of the all workshop. And please come all back here at 3:30, inshallah, for recognition of the workshop moderator and also for recognition for the CIC certification. So we'll meet you in the workshop at 1:45 and 3:30 here, inshallah, in the main hall for the recognition of the workshop moderator and CIC certification, inshallah.